Morning everyone. Sir, sir. Morning everyone. On behalf of Chair Scientific Committee, Bihar Congress Society, I welcome you all. Today's session, first session, and this is the ninth midterm conference of Bihar Congress Society. I must thank the local team headed by Dr. Abhiranjan sir, Amitabh Singh, Dr. Amresh Krishna, Dr. Manoj Kumar, Dr. Abhishek Kedia, Dr. Arvind Kumar, and all the local people and senior person, Dr. Kian Tiwari sir, who has organized a lot with a good venue and good food. We are going to start our first session. A little bit change in the session because somebody is coming from Patna. So we are going to start Salab sir, and my request moderator of this session, Dr. Nilesh, Dr. Santosh and Dr. Nidhi to start this session. Dr. Nilesh.
Thank you so much, sir. So, for this session, the chairpersons are Dr. S.K. Rungta, sir. Sir, please come on the dais. Dr. Deepak Kumar, sir. Dr. Sunil Parmar, sir. Dr. M.R. Rumi, sir. Dr. Ravi Ranjan, sir. And co-chairperson, Dr. Amitabh Singh, sir. Pooja ma'am is still on the way. Manoj Kumar Singh, sir. Pallavi ma'am. Amresh Kumar Singh, sir. Dr. Ashish Sharma, sir. Sir, it's not. Sir. So we will start with the first talk. Dr. Salab sir is going to talk about hooks and CTRs in cataract surgery. Sir.
Good morning, everyone, and thank you to the organizers for allowing this presentation early. I had thought that while coming to the venue, I'll sit in my car and I'll finish, making the videos and whatever. But I chose to ride a bike. So this video is only a single video. So you can see this is it's not playing. Chala. So this is a post-traumatic zonular dehiscence, and one fine day in the operating room, the patient had come from Muscat, and he had sustained trauma about a year back. So you can see the wrinkles in the anterior capsule and zonular dehiscence almost 180 degrees. So the plan was to put in a CTR in this case, and of course the initial, while doing the cataract surgery, so you can see the amount of zonular dehiscence, and one has to be really careful while doing the rhexis in these cases. So this is a slightly fast forwarded video because it's a long video. So in the interest of time, it has been fast forwarded. So multiple side ports, and these are the capsule hooks that go in to provide the artificial support. Because of the missing zonules, you need to put in these hooks so that the capsular bag is stable while doing the removal of the cataract. Cataract is not very hard, it's a soft cataract. So hydro, and then in spite of it being a very soft cataract, I was able to, you can see I was able to rotate the nucleus in the bag. Multiple, you have to fill in the bag with viscoelastic. Tried the stop and chop. It was very, very soft. I wasn't able to chop it as well. So slight struggle. So soft cataracts are not that easy. Another, putting in another hook, because I felt that the capsular bag was also compromised in that region. So another hook goes in. So these hooks are different from the iris hooks. These are meant for the capsule, and ideally one should not use a iris hook for these cases. So once the bag was very, very stable, then the soft cataract was almost, rotated in a cartwheel kind of fashion, and so that's done. So now the plan is to put in a CTR, but then that day I had just one CTR, and this patient has come all the way from Muscat, and now the CTR, I have lost it. So unfortunately I lost the CTR, no matter how much I had tried to, I'm trying to bring that CTR out. नहीं हुआ. फिर मैंने finally, I'll just stop it here. कभी कभी जुगाड़ करना पड़ता है. So CTR injector had 2 small screws. So I had to open the screw and then push the CTR using a 18 gauge needle, and that's how the CTR came out, slightly deformed, because सिर्फ CTR निकालने में मुझे आधा घंटा लग गया. So the CTR came out. उस दिन unfortunately एक ही था. So always when you have to do these cases, have a spare. कहीं गिर जाए, कहीं फंस जाए. So it was a little struggle trying to put in the CTR because it had become deformed. But somehow managed to bring it into the anterior chamber, still struggling, and then finally managed to put it in the capsular bag. Then your normal irrigation aspiration to remove the cortex, the implantation of the intraocular lens. Another thing to remember always is that when you are implanting the intraocular lens, have your capsule supporting system there, because sometimes while implanting the intraocular lens, if you have removed your capsular hooks, sometimes it becomes a little difficult to do this. Then a little bit of anterior vitrectomy. I felt that there was some vitreous there in the anterior chamber, and then once you've done all that, just checking for any remnants, remove your hooks and complete your case. So this is what I wanted to share. Thank you.
Dr. Salam,
Yes, sir.
there are many PGs also here.
Yes, sir.
Will you like to comment about the difference between iris hook and capsular hook?
So the capsular hooks are slightly, as you saw, unlike the iris hooks have a very shorter portion which actually is meant to engage only the iris. This has a longer and a slightly, the bend is little different, and it supports the capsule margin of the, it doesn't tear the margin. With iris hooks I have encountered that sometimes the rhexis margin can get torn. So one should not use iris hooks in place of capsular hooks. You must always have capsular hooks if you want to support the capsule.
Because of this reason, we must not use iris hook while capsule is to be retracted. And second question is, it was long 30 minutes you could do the jugaad of that. Yeah. How that 30 minutes passed, and the patient was literate and he was from Muscat. So in such a situation, there is usually so much of noise in the OT. Ye kadiye, halla gulla. So how did your patient responded to that?
अगले दिन बोला सर आप तो कबीर सिंह बन गए थे. इतना आप डांटे इतना ओटी स्टाफ को, क्योंकि ओटी शुरू होने से पहले मैं बोल रहा था सीटीआर कहाँ है सर, आ रहा है सर आ रहा है सर, आ रहा है सर. ओ आते आते उसको बहुत देर लग गई, फाइनली आया ही नहीं.
So just wanted to ask you about what is the advantage of having that injector over the manual insertion that you did?
Yeah, so what I do with the injector is that the leading part of the CTR, I engage it with the Sinski. So it doesn't push the rhexis and it doesn't push the bag. So slowly you're injecting. There's no stress on the remaining zonules, because if you just dial it in, there are chances that you can tear. अभी परसों ही हुआ है, CTR इंजेक्टर खराब हो गया. I was just trying to dial it, rhexis फट गया. So if you have an injector, it is more controlled and it has less stress on the zonules. If you engage the leading part with the Sinski, let it get injected almost completely, then release the leading part and then the trailing part.
Thank you, sir.
Thank you, Dr. Salab.
Dr. Salab, there is one more query.
Yes, sir.
For the benefit of house also. What should be the direction of CTR leading edge end? Whether it should be toward the dialyzed part or toward the normal area?
If you are not engaging, the difference comes when you are not engaging the leading part. If you are engaging the leading part, doesn't matter where is the dialysis, but ideally the CTR should go towards the area of dialysis. If you do it in the opposite direction, you will increase the area of dehiscence.
Okay.
जैसे अगर इस तरफ है और आप उल्टा तरफ से डाल रहे हैं, तो जो बैग का जो पुश है वो उल्टा तरफ जा रहा है. लेकिन जब आप उसके तरफ ही डायल कर रहे हैं, तो स्ट्रेस नॉर्मल पार्ट की तरफ है, इस तरफ नहीं है.
एक्चुअली मेरा ये सोचना, अगर मैनुअली हम तो ज़्यादा डाले हैं तो उसमें जो सी टाइप जो हुआ है, एज भी दूर था उससे डायलिसिस पास थे, ताकि उसको पंचर नहीं करे, क्योंकि वहाँ पर स्टेबल है नहीं. और तो उधर जो लीडिंग है जो एज था वो नॉर्मल साइड चला गया था अपने आप ही, और उसके समय जो उसका जो कर्व्ड पार्ट आर्क वो चला गया डायलिसिस की तरफ. तो हमको लगा उसमें ज़्यादा सेफ था.
नहीं, always you should insert towards the area of dehiscence, because your normal zonules are supporting your capsular bag. अगर आप उल्टा तरफ से डालिएगा, dehiscence increase होगा, zonular dehiscence, क्योंकि उल्टा तरफ है ना, आप बैग में डाल रहे हैं.
So this was the last talk, because it was the last talk of the conference actually, because it required a lot of discussion and no time bound was there, but now we are short of time. So next I would like to involve Dr. Vaibhav. He is going to talk about combination therapy in glaucoma, a clinical comparison of dorzolamide with timolol and brimonidine.
Good morning and welcome to the 19th midterm conference of Bihar Ophthalmical Society, BOSS at DOS. Hello. Good morning and welcome to the 19th midterm conference of Bihar Ophthalmical Society, BOSS at DOS. I'll be speaking about combination therapy in glaucoma. I'd like to thank the local organizing committee, especially Dr. Ravi Ranjan sir and Dr. Amitabh sir, for giving me this opportunity. My topic is combination therapy in glaucoma. a clinical comparison of dorzolamide timolol and brimonidine and timolol. Why is there a need for combination therapy in glaucoma? So, in landmark studies such as ocular hypertension treatment study, 40% of the treated subjects required more than one medication to achieve the therapeutic goal of 20% reduction from baseline. And in collaborative initial glaucoma treatment study, 75% of subjects required 2 medications after 2 years. The increasing complexity and burden of treatment reduces the adherence rate to the treatment. Fixed combinations are highly effective and reduce the complexity of glaucoma medical therapy, along with lower exposure to preservatives and reduction in washout effect. Decision tree for adding a second drop. So this is very complex. If the target pressure is not achieved, and if there is significant progression is noted, we can either go with a second drop or we can plan for a surgical intervention. Why the choice of combination therapy matters? See, both brimonidine timolol fixed combination and dorzolamide timolol fixed combination have been shown to potent and efficacious ocular hypotensive agent, but glaucoma therapy extends beyond IOP control. Factors like ocular blood flow, durability of IOP control, and diurnal fluctuations matter. Dorzolamide timolol and brimonidine timolol both have similar IOP lowering efficacy. Both have shown to reduce IOP by around 29 to 31%. However, dorzolamide timolol fixed combination has significantly better 24 IOP lowering efficacy than brimonidine timolol, especially at 6 o'clock and 2 o'clock. 6 o'clock in the evening and 2 o'clock in the night. And 65% of patients with glaucoma progression have nocturnal IOP elevations. So DTFC has a better nocturnal efficacy than brimonidine. Brimonidine also showed significant IOP reduction, but at 3 time of point, at midnight, 3 a.m. and 6 a.m., it was not as effective as dorzolamide timolol combination. Beyond pressure, the vascular theory of glaucoma. Many published studies have reported that reduced ocular perfusion in glaucoma patients compared with normal subjects. Glaucoma is linked to impaired ocular blood flow, often due to vascular dysregulation, not atherosclerosis. Unstable ocular perfusion can lead to ischemia, reperfusion injury to the optic nerve. DTFC significantly improves ocular perfusion in primary open angle glaucoma patients when compared to brimonidine timolol fixed combination. Now here we can see with DTFC combination there was the ocular perfusion pressure was best with DTFC combination after 6 weeks. Dorzolamide also shows sustained efficacy over time. There is long-term drift with IOP lowering agents, most pronounced with timolol, but is also observed with brimonidine. It is not seen with dorzolamide or other prostaglandin analogs. Conjunctival hyperemia is more frequently reported with brimonidine timolol fixed combination when compared to dorzolamide timolol fixed combination. And 16.7% of patients reported conjunctival hyperemia using BTFC instead of only 5% who reported in DTFC. Brimonidine is known to cause significant allergic reaction in cornea and conjunctiva after long-term use. Here we can see a typical allergic follicular conjunctivitis. Allergic reaction do not occur instantaneously after instillation of topical medication. Brimonidine may reduce the volume of conjunctival cells and widen intracellular space. Potential allergens may subsequently enter subepithelioid tissue and result in follicular reaction. Mean interval from initiation of brimonidine to onset of allergic follicular conjunctivitis was 6 to 9 months. However, the interval differed widely among studies, ranging from 14 days to as late as 12 months. However, 6 to 9 months have been the mainstay. 53% of patients on brimonidine timolol fixed combination experienced one or more treatment-related adverse event. Allergic reaction to brimonidine may be associated with loss of IOP control, and 5.6% of mean IOP increase after onset of allergy, ocular allergy was seen with brimonidine. So the choice of combination therapy matters. Fixed dose combination improve adherence, lower preservative exposure, reduce washout effects. DTFC and BTFC offer similar efficacy during the day, but DTFC offers superior 24-hour and nocturnal IOP control. DTFC enhances ocular perfusion pressure, thus catering to vascular component of glaucoma. BTFC is associated with more allergic conjunctival reaction and potential loss of IOP control. DTFC maintains efficacy over time with fewer tolerability issues. Thus, out of the two combination, dorzolamide timolol fixed combination is a better choice. Thank you.
Thank you so much, sir. I think I'd just like to take one question because we are running late.
Dr. Vaibhav, now after 2 drug combination, now 3 drug combination is in the market.
Yes.
Any special message to the audience that when they should use 3 drug combination? It's not that, and companies are advising you start with this. This is the wrong message.
So the recommended preferred practice pattern from AAO and EGS recommends single drop to be initiated, prostaglandin analogs to be initiated, and after 3 months, if the baseline reduction in IOP has not been achieved, then to go for a second drug. But with 3 drug, if there is severe to advanced loss of field, then it is preferred choice, because then we'll be seeing on IOP reduction as well as perfusion pressure.
So the message to the audience is don't jump for 3 drug combination. Don't be provoked by the companies and start with monotherapy, then 2 drug, and if you really need 3 drugs, then only you switch on the 3 drug combination.
So one
Thank you.
question, if I can ask. So how do you measure the ocular perfusion?
Ocular perfusion pressure will be measured with mean diastolic pressure minus the IOP, sir.
Okay. So you're not actually measuring it inside the
No, sir,
eye.
no, sir.
And another question is that because बिहार में है, patient आपका afford नहीं कर सकता है,
जी sir.
तो normally we would like to start with a drug that is less
Cheaper, less affordable,
costly,
मतलब more
क्योंकि-
affordable, sir.
हाँ, so अगर आप prostaglandin analog पे जाइएगा तो फिर 300, 400, 500 से कम में नीचे तो
जी
ड्रॉप ही नहीं
जी
है,
सर, जी सर,
और अगर उसको लाइफ लॉन्ग डालना है तो आपको वो भी देखना पड़ेगा।
जी सर.
और 3 ड्रग पे अगर आपने पेशेंट को अगर 3 ड्रग पे ले ही आना है तो सर्जरी क्यों नहीं कर दे रहे?
जी सर, जी सर.
So that is the community approach. I think that
Thank
that
you.
is the next session. We will start with the PG free paper. The judges for this session are Dr. Praveen Krishna Vadavali sir, Dr. Devakant Mishra sir, and our own Dr. S.K. Rungta sir. They are going to judge this session. Dr. Vibhuti sir, please come as chairperson on the dais. So the first presenter is Dr. Rashmi, and she is going to present her case report of right eye subluxated lens and left eye anteriorly dislocated mature cataract in a patient with Marfan syndrome. Over to you. All the best.
Good morning, everybody. I'll be presenting a case report of right eye superotemporal subluxated lens and left eye anteriorly dislocated mature cataract lens in a patient with Marfan syndrome. I'm Dr. Rashmi from Narayan Medical College and Hospital, Jammuhar. Marfan syndrome is a multi-systemic genetic disorder that affects the connective tissue. Worldwide, the incidence of Marfan syndrome is approximately 7 to 17 out of a lakh population. It is caused by mutation in the FBN1 gene on chromosome number 15. One of the genes, this is one of the genes that makes the fibrillin, which results in abnormal connective tissue. Altered FBN microfibrils causes incompetent zonular fibers and structure abnormalities of the lens capsule. It is an autosomal dominant disorder, And in view of importance of the ocular manifestation of Marfan syndrome, we decided to report a case of a 16-year-old boy named Darwin who presented with lens subluxation in right eye and anterior lens dislocation in the left eye. So the case report goes that a 16-year-old male patient presented in the ophthalmology department of NMCH on 10th of March 2025 with a complaint of diminution of vision in left eye since 2 years. The patient was apparently asymptomatic 2 years back when he developed diminution of vision in his left eye, which was insidious in onset, gradually progressive, and was not associated with any pain, redness, photophobia, or watering. It is to be noted that there was a history of fall from height, which was 2 years back. On general examination, it was seen that he was a tall boy, thin tall boy with his arm span more than the height. His height was 189 centimeter and his arm span was 195 centimeters. He was conscious oriented. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. The vitals were normal. On systemic examination, we found that the in respiratory system, there was bilateral normal vesicular breath sound were heard. In CVS, S1, S2 were heard, no murmur was there. CNS, on a CNS examination, he was well oriented to time, person and place. Per abdomen was soft and non-tender on palpation. There was no facial symmetry noted, no abnormal head posture was noted. His musculoskeletal examination was done and there was no vertebral deformities. Echocardiography, there was no abnormality and ECG was normal. This is the height versus the arm span of the boy. Arachnodactyly was present. Thumb sign was seen as it is usually seen in Marfan syndrome. Wrist sign was positive. These figures show that he had high arched palate. He had flat foot and pes excavatum was present. On ocular examination, in his right eye, vision was 3/60 and with pinhole it was 6/60. In left eye, it was hand movement and there was no improvement with pinhole. Lids, conjunctiva and cornea were all within normal limits. Anterior chamber depth in the right eye was normal, but in the left eye, the anterior chamber depth was decreased and mature cataractus lens was present in the anterior chamber. Pupil was normal in right eye, but in the left eye, since there was a mature cataract in AC, we could not assess the pupil. Iridodinosis was present in the right eye, and in left eye it was normal. And lens in the right eye, there was phacodonosis, superotemporal subluxated lens, blue dot cataract was there. Absence of zonule in the inferonasal quadrant from 2 o'clock to 6 o'clock, which is 4 o'clock of zonular absence was there. And in left eye, there was anterior dislocation of mature cataract. During fundus examination, we did it with slit lamp biomicroscopy with and with plus 90D. Cup disc ratio in the right eye was 0.7 to 0.8 and macula was normal. In left eye, it could not be assessed. Intraocular pressure was measured by Goldman applanation tonometer. In right eye, it was 36 mm of Hg. In left eye, it was 24 mm of Hg. Lacrimal apparatus and extraocular movement were normal, and extraocular movement was present in all gazes. This was the this is the figure of the eye. In the right eye, there was subluxated lens, and in left eye, in the anterior chamber, there is mature cataractus lens. Each case of lens or IOL subluxation needs to be evaluated individually to analyze any risk or benefits of the procedures. The patient was started on anti-glaucoma drugs. In this case, the decision of combined capsular tension ring implantation and phacoemulsification plus IOL implantation was done in the right eye. Further follow-up is needed to assess long-term evaluation of the patient with zonular instability that required the usage of capsular tension ring. Plan of treatment for the left eye is phaco aspiration with scleral fixated IOL and pars plana vitrectomy. The need to prevent the ocular complication is the justification for our plan to review the patient periodically. Follow-up with cardiologist and orthopedician was suggested to improve the quality of life and to detect any life-threatening complications that could be present in the Marfan syndrome, like dissection of aorta easily. When it comes to the diagnosis and management of people with Marfan syndrome, ophthalmologists are very crucial, and early detection and appropriate visual rehabilitation coupled with multidisciplinary management are crucial for improving both the visual outcome and overall prognosis in affected individuals. Thank you.
Thank you. Judges, please note Shiva's 15 seconds over time. Please, judges' questions.
Just few comments, Dr. Rashmini. So, it took you around 3.5 minutes to reach the finding of the lens, which was, what we were looking for. And so all the general findings, the systemic findings, of course, cardiovascular and these things were important in this case, but you can rush through that when presenting a case. Even in your exam, probably, just focus on the positive findings. One more comment, you mentioned, I think, the name of the patient, which should ideally be avoided. You should try to protect the identity of the patient. And we would have loved to see more about, how the surgery was done and what we would have discussed that more, right?
Okay, sir. Thank you, sir.
Dr. Praveen.
Hi Rashmi, I'm here. So nicely laid out presentation, but I think when you're presenting a case that is relatively well described in literature, because Marfan syndrome is known to have things like this, would be also good to compare with what is usual, like what percentage of cases you have anterior subluxation, what is the direction of subluxation, and what is unusual about this as compared to other cases that you have in literature, and then bring out that aspect and then talk a little bit more about the management.
Okay, thank you, sir.
Thank you.
Thank you, sir.
Hello.
Thank you. So the next presenter is Dr. Renuka J, and she's going to talk. Yes.
Hello. Dr. Rashmini, can you tell me what is the basic pathology? So the lens is dislocated or subluxated. Where is the pathology?
Sir, due to the gene abnormality, there is a defect in fibrillin microfibrils, which causes weakening of the zonules. And it's more commonly seen in the inferonasal part. So due to that, there is superotemporal subluxation seen in Marfan syndrome. Also, sir, there is, in my case, there is increase in the intraocular pressure, and that is because in Marfan syndrome, we generally see trabecular meshwork dysgenesis due to deficiency in the fibrillin protein.
Yes.
Thank you, sir.
And this is just, by the way, can you name any famous person with Marfan syndrome?
Sir, actually, sir.
This is just, by the way, this is not included in your competitive year.
Sir, Abraham Lincoln was
Yes.
one of those. Thank you, sir.
Very good. Thank you.
So next we have Dr. Renuka J, and she's going to present haptic stabilization in sutureless scleral fixated IOL, a novel approach.
Good morning, everyone. Today I'll be presenting a free paper on the topic Haptic Stabilization in Sutureless Scleral Fixated IOL, a novel approach. No financial interests or conflicts to disclose. Inadequate capsular support pose a unique challenge. Capsular deficiency can either result as a result of a complicated cataract surgery or post-trauma, or due to connective tissue disorders like Marfan or other syndromes like pseudoexfoliation. Scleral fixated IOLs are preferred in such cases where the IOL is placed in proximal to your natural lens position, which avoids complications related to your cornea and that offers a better visual acuity. Further, going sutureless avoids suture-related problems like erosion, breakage, and thereby IOL dislocation. Yamani's technique have proven to offer more reliable fixation in terms of IOL centration. The aim of our study is to describe a novel approach for exteriorization of the haptics in sutureless scleral fixated IOL and to assess its efficacy, and it is a prospective interventional case series. 4 cases were presented with aphakia. For secondary IOL implantation were included. Anterior approach of sutureless scleral fixation was done. A 3-piece IOL was used in all the cases, and the optic insertion was done as described by Yamani, but flanging was not done in these cases. Exteriorization and stabilization of the haptic were done with the help of a high-risk hook plug inserted in a bent 26 gauge needle that were used to bring out the haptic of the optic and keep it in the place, avoiding the need for like the second surgeon to hold the haptic in place while the surgeon is manipulating the other haptic. The optic of the haptic will be brought through the bore of this 26 gauge needle and brought out and tucked inside your scleral pocket, which was made already. And post-operatively, visual acuity, IOP would be recorded, and centration and degree of tilt of the IOL would be documented with the help of an anterion at the end of 1 month. And these are the case details. The first case was of a 7-year-old female who presented post-cataract surgery for secondary IOL implantation at the age of 7 years with a visual acuity of 2/60. And we went for a scleral fixated IOL. This is the first image where you can see the 26 gauge needle haptic being introduced to the bore, and globe stabilizer being used, and the IOL being implanted. And post-operatively, our visual acuity was 6/60, but our IOP was on the higher range, a little higher range, which we have to manage with medical management, and it was under control now. And this is the 1 month post-op. The IOL is in center, and patient has a visual acuity of 6/36. Second case was of uneventful cataract surgery. The patient was well for 1 month. Then after that, she presented with aphakia and a vision of finger count close to face. And in the anterior segment examination, we could not see anything, but in the posterior segment, we can see the IOL being dislocated in the anterior vitreous face. And we went for like a IOL explantation of the same, and it was a 3-piece IOL, and this was like same IOL was implanted in the patient, but post-operatively on POD1, the IOL was inferiorly dislocated, and we had to go for a surgery again. And with the surgery with the new IOL, our vision was 6/24, and the IOL was centered at POD28 also. And this is a case of post-trauma. He had to undergo 2 surgery. After that, he presented with the vision of 3/60, and we planned for surgery at the SFIL using the same technique, and his vision was improved to 6/12 post 2 surgery. And the other patient was also a patient of trauma post scleral tear repair, and who presented with a visual acuity of finger count close to face, and there was no capsular support, and he had a scleral tear repair already done. The approaches to, we have to make a corneal incision for the optic to be inserted, and this is the in intraop we are using a toric marker to make the scleral pockets, and this is one important step. Though the scleral pocket should be at 180 degree to each other, and this plays an important role for your IOL to be centered post-operatively. And this is the visual acuity post-operatively. Whose vision was 6/12 and IOL was centered. And this is the pre-op and post-op comparison, like where you can see the vision from finger count close to face post to trauma improving to 6/12. In all the cases, we could achieve a centered IOL, and there was no tilt. And only in one case, which that pediatric cataract, we got the decentered IOL, and we need to go for redialing. Showing the results, 2 indications for the surgery. 2 cases had a history of trauma, and 2 cases had previous complicated cataract surgery. Then we had to go for SFIL, and the complications we faced were increased IOP post-operatively, and 1 patient had a decentered IOL, for which we have to go for reimplantation. Coming to discussion, use of high-risk plug hooks is a novel and a cost-effective approach, helps in exteriorization as well as stabilization of haptic, while the surgeon can manipulate the other haptic, avoiding the cumbersome efforts of a second surgeon. And it provides a good alternative to other devices available such as XNet. And going for a sutureless approach and tucking the haptic inside the scleral pocket and providing a centration, as we could see here, will be a better alternative compared to costlier alternatives like using fibrin glue. A retrospective study by Ko et al. And Sen et al. Have shown IOL dislocation and raised IOP were more when we go with an anterior approach, and those 2 complications were seen in our cases, which could be managed. And lens tilt can be minimized by using a 3-piece IOL that has a haptic design that covers your entire ciliary sulcus. And previous studies have shown an IOL tilt of 2.3 degree with the use of SOIL, which is nothing more than a normal in-the-bag implantation IOL in routine cataract surgery. Take-home message, in terms of visual recovery, there is no difference in case of an SFIL, ACOL or iris claw lens, but in terms of long-term complications, a scleral fixated IOL stands out. Though every step in an SFIL has a steeper learning curve, because of its superior visual recovery with a better safety profile and longer-term less complications, it stands out to be the best, and use of a high-risk hook plug retractor will be a cost-effective alternative. Thank you.
Thank you, Dr. Renuka. She was well within the time limit. Judges, questions, please. Praveen, sir.
I'm here, Renuka. Thank you for the series of cases. So, in effect, you were evaluating the use of the iris hook ring in ensuring that the lens does not move from its position long term?
No, we are not like keeping it as such, sir. While intra-op manipulation, other surgeon has to, when you are exteriorizing one haptic, while you have to manipulate the other haptic, one surgeon has to hold it, or there are chances it might, while manipulating the other haptic, this haptic might also come again inside. To stabilize it, there are devices like XNet and all, and one can hold also, but this iris hook plug retractor will be like cost effective option. Just we will, after exteriorizing your haptic through the bore of the 26 gauge needle, you will plug the haptic with this iris hook plug retractor, and it will stay in its place so that the surgeon can manipulate the opposite side and the surgery could be done.
Yeah.
So like it's easy a little.
Yes. So which is nice, but then I think when you're reporting the outcomes of this new technique, the measure of the outcome should also be what is the difference that this is adding. Like say for example, intraocular complications that you have dislocation or subluxation or slippage compared to the regular technique, that would be a difference in this new technique. Because IOP, decentration probably are not related to the new technique. They're going to be there anyways, right? Yeah, but nicely presented. Thank you.
Thank you, sir. Rungta sir, any comments?
Just for the sake of academic interest, can we have some comment from Dr. Tiwari?
What I could find from your presentation, that there is only difference from XNIT from your technique is you are using that iris plug to hold the haptic, while in external needle assisted technique we are using that cut part of 240 belt buckle, remnant of belt buckle. So this is almost same technique, just only that you have used that iris plug, and in XNIT it is being used as that cut part of that belt buckle. So I think it is almost same technique. There is nothing different as compared to XNIT or your technique. Just the material used for holding the first haptic. The main aim of your technique or XNIT is that first haptic should not go inside the eye when we are manipulating the other haptic, that trailing haptic. And sometimes we used to ask our assistant to hold the first haptic, but since they are not seeing through the microscope, sometimes they might pull, or sometimes that haptic may slip from their hand and it go inside, or they may break also. So this was devised that something there should be some plug which holds the first haptic, so that the second haptic, while manipulating second haptic, the first haptic should not go inside the eye. So in XNIT, a small cut part of 240 band was used, and you are using that iris plug. That's it. I think that is the only difference from XNIT to your technique. Is it so?
It would be cost effective, sir.
Yeah, that cut part of belt buckle is also, that doesn't cost anything. That is just a remnant waste of, but yes, that is available only in retina OTs and not anterior segment OTs.
Thank you, sir.
After Tiwariji's comment, I am not going to put any comment on especially scleral fixated IOL. His experience is much more, and I do agree with that, because I was asking him whether without seeing that concept how it is helping, it is very difficult to visualize things what is being done on the table right now.
So the other two participants have just arrived because the bus was a little late. So we will have Dr. Rungta sir's talk, the keynote address on fungal keratitis. Be careful first, and then move on with the free paper.
At the outset, I am very much thankful to BOS and Professor Gyanji, Dr. Satyajit Sinha, for giving me this opportunity to give a keynote address before you. Fungal keratitis, let us be careful. No financial disclosure, no conflict of interest. Fungal keratitis, or we say keratomycosis, is one of the most serious, destructive and difficult forms of microbial keratitis to diagnose and to treat successfully. There are so many cornea people over here. I will like some addition and some healthy comments after the talk to be wiser. Fungus are eukaryotic heterotrophic organisms, and fungus may be part of normal external ocular flora also. Worldwide, It is significant cause of ocular morbidity and unilateral blindness. It is primarily seen in tropical climates and is rare in temperate areas. Filamentous fungi are more in tropical climate, whereas yeast or candida, these are more common in temperate. More than 1 million cases of fungal keratitis are diagnosed every year. 10% may result in corneal perforation. In the past, 50% patients with fungal keratitis were losing their vision in that eye to some extent. This figure is improving now with better management. These are some fungi. Aspergillus is common, and these are laboratory groups. For example, these are filamentous septate fungi, Aspergillus and Fusarium. These are non-pigmented, and these are pigmented fungi. Mucor is filamentous, non-septate, and Candida is non-filamentous, yeast. Aspergillus, as I said, being most common. Fungi gain entry into stroma through a defect in epithelial barrier. In stroma, it causes tissue necrosis and host inflammatory reaction. This can penetrate deep into stroma. These are different risk factors, especially trauma, more so by vegetative matter. This type of cases we get more. Contact lens use, prolonged topical medications with corticosteroid or sometimes with anesthetic abuse, broader spectrum antibiotics, or immunocompromised state. In ocular trauma by vegetative material or in contact lens wearer, more chances of filamentous fungi. And in pre-existing ocular disease or after prolonged use of steroid, when we get, there are more chances of non-filamentous. These are the classical symptoms and these are the classical signs. But what we should remember is dry, feathery, plaque-like appearance with ring infiltrate and occasionally satellite appearance. This indicates fungi, unless otherwise proved. This is early fungal ulcer. This is ulcer with hypopion. This is hyphate. This is corneal abscess, pigmented ulcer, and satellite lesion with hypopion, stromal infiltrate with feathery margins. There are different type of stains for laboratory diagnosis. I will not go into the detail of that. And nowadays, trypan blow is also being used here. But KOH preparation should be done at every center. This is easier, and this is cheap, simple method of diagnosis with sensitivity from 70 to 90%, and this is the appearance. The mechanism of this is KOH dissolves human tissue, leaving alkali resistant structure so that it allows visualization of fungi. These are different culture media, but Seborrhoeic dextrose agar is most popular, more because of this contains an antibacterial agent, thus promotes the fungal growth. There are newer methods for diagnosis, anterior segment OCT to see the activity of the ulcer, electron microscopy, confocal, and PCR. Now AIE is being used in this also. Recently, AIE is being used to design an instrument similar to OCT of retina for quantifying the prognosis of fungal keratitis. And Dr. Prasanna Venkatesh is working on this project. As far as treatment is concerned, it is difficult to treat sometime. Only few drugs are freely available. Penetration of the drug is poor. So poor bioavailability, toxicity of the systemic drugs, and drug sensitivity difficult to determine. Atropine we usually give for breaking the synechia and to preventing it from synechia, to reduce the pain and to reduce tear secretion so that their lysosomal content of the tear is increased, and it separates the corneal lamellae also to help the penetration of the drug. Right. Diabetes, if it is there, must be looked for, and status, immune status should be looked for. Topical antifungal medication is the mainstay. Drug of choice is natamycin, but there are other systemic, intrastromal, intracameral routes may be used for other drugs. There are different drugs. I will not go into the detail. And this topical natamycin is the best. This is well proved by both MUT1 and MUT2 study. Poor penetration limits its use in deep keratitis. For other alternatives are amphotericin B. this is one peculiar drug which can be used by any route, topical, subconjunctival, intrastromal, intracameral, intravitreal, or intravenous. So the basic treatment is natamycin, and many a time I find in the prescription natamycin 4 times or 5 times, but I think it should be given hourly in early stage for 2 days at least, then 2 hourly, and in night time also this must be insisted to be used. Voriconazole, if used 1% solution, this is to be made from the parenteral formulation, used for recalcitrant cases not responding to natamycin. There are other alternatives also, itraconazole. Then indication of systemic antifungals, severe deep keratitis, voriconazole is the best choice, scleritis, recalcitrant keratitis, endophthalmitis. And these are the systemic antifungal agents, voriconazole, ketoconazole, itraconazole. Intrastromal, if you have to give, voriconazole gives the best result. There are few antibiotics with antifungal property, chlorphenicol and moxicillin. Providone iodine is nowadays not being used for this purpose. And these are the different methods of surgical management, but debridement is important. One must practice this. What are the factors associated with treatment failure? If it is large corneal ulcer, presence of hypopyon, immunocompromised status. And what are the drawbacks of fungal keratitis? Fungal infections are notoriously resistant to treatment, takes days to culture, weeks to heal, treatment failures are high, and particles of natamycin remaining in the eye and causing irritation also. Complication, the important complication is perforation that we have to manage, and we have to prevent the corneal perforation. So how to minimize treatment failures in fungal keratitis? Start earliest treatment, frequent and close follow-up. In trauma cases with mild superficial fungal keratitis, natamycin in proper dose. In deep fungal keratitis, try other options. Cleanliness of the periocular surface must be insisted. Drug compliance should be taken care, and a big no to steroid, never to be used steroid. This natamycin is the first drug of choice. May add voriconazole if there is no response. Systemic voriconazole has a role to play in fungal keratitis. In intracameral and intrastromal therapy is used in recalcitrant cases, and no overuse of lubricating. At the initial stage, we used to give lubricating drugs, but that will dilute your medication. Thank you.
Thank you so much, sir. I think I would like to invite comments from Praveen, sir. Praveen sir, what is your thoughts on, because we are in the area where we don't have corneal scraping available to us very readily. So what do you think is the role of empirical therapy in cases of fungal keratitis presenting at first?
I think first Professor Rangta sir has covered, I think, the entire textbook on fungal keratitis, very nicely done. But availability of scraping depends on us. The microscope costs 10,000 rupees. The KOH costs a couple of hundred rupees. So it's just the fact that we have to invest this and then start doing it. Not doing it and not having access to it is not an excuse.
Nilesh, if you permit, we would like to have one-line comment from Dr. Ashish.
Yeah, so I was going to him only because I have seen his prescription where he prescribes only antifungals in fungal keratitis, which I don't. I also add antibiotics. So, sir, your thoughts on that?
A very nice presentation, sir. You have covered everything. Just that most of us start cocktail therapy for any of the microbial keratitis. I think if we are suspecting fungal keratitis, which takes a couple of days to progress, so it is a good idea to start just with the natamycin and then add later any other antimicrobials if required. And hourly, as mentioned, because as mentioned by Rungta uncle, MUD study clearly stated that natamycin should be the first choice in a case of filamentous fungal keratitis, especially if it's fusarium, if we are suspecting. And in our region, we have seen fusarium is much more common than aspergillus. The second thing is about the microscopy. It's actually very easy to do and doesn't require much of infrastructure. And instead of KOH, we can use methylene blue, which we use in OT every day. I just put a drop of methylene blue on the cover slide over the scraping, and you can see fungal filaments very clearly, much better than KOH in just a couple of seconds. So I think each of us can practice. If we don't have time, we can train our assistants or paramedics in that.
Thank you, sir.
Any comment from Dr. Abhishek?
I'll ask you one more additional question to this. The role of corneal scraping not in diagnostic but also as a therapeutic option in each visit, ma'am. Your comments.
Definitely, yeah. I think the worst thing to do an ulcer is to start a cocktail. So it's quite easy to do, as Ashish also told. Praveen sir is there, definitely. So we can do a scraping in our settings only and come to a conclusion. And second thing I would like to add on is that the bactericidal drugs actually decrease the action of fungicidals. So it's not a good thing to start a cocktail. Thank you.
Sir, Nilesh, sir, your comments and then we will conclude.
Most of the topic has been covered, I think, by Dr. Rungta sir. Having said that, not starting the antibiotic, but I think by the time the patient lands up to us, he has been given a mixture of drugs. At that point of time, you can use the antibiotics in a very less frequency and focus on the fungicidal, which you are actually doing. So that is what we follow and we try to do that.
Dr. Nilesh, just one more query from us. Whether seeing the color pigment of fungi over the corneal ulcer, can we suspect some type of, can we differentiate it clinically also? Please.
Those can be can go to Aspergillus species in case of black pigmentation, but differentiating species clinically is difficult. Ashish?
These are a group of demititious fungal keratitis, and they are a different organism. But again, we don't have much choice. We have just natamycin and voriconazole in most of the cases. So the treatment remains the same. It's just that we may prefer to use voriconazole in these patients as compared to natamycin.
So I'd like to ask Abhishek sir for his
very good presentation.
Role of any fluconazole or oral antifungals?
Oral antifungal, I think Rungta sir has well covered that in which condition we have to give oral antifungals. Fluconazole have a role in candida infection better than like fungal, filamentous fungi. Better voriconazole tablet is a good option in all the cases, but is a very costly. That is not very cost effective in this region. I think in that place we can use itraconazole or ketoconazole tablet also. That is very similarly effective. Regarding regarding that that pigmented fungus, I think that fungus is responding very well to treatment with the natamycin or voriconazole.
So, thank you, Rungta sir, for that wonderful talk. Next, I would like to restart the PG free paper session with Dr. Surbhi Tiwari. Dr. Surbhi Tiwari, your presentation is up. So she's going to talk about impact of low vision aids and visual impairment among patients attending a LVA clinic, a case series.
Good morning everyone. My topic is impact of low vision aid in visual impairment among patients attending a LVA clinic. No financial declaration, ethical clearance taken. WHO working definition of LVA defines person with low vision as one who has visual impairment or visual function impairment even after treatment of ocular pathology, vision of less than 20/60 to a perception of light or a visual field of fewer than 10 degrees. It's important to qualify the quality of life of those with low vision so that effects of low vision rehabilitation is determined. Global statistics in India, low vision remains under-addressed due to lack of awareness, stigma, unavailability of trained LVA services. Aims and objective: measure improvement in vision-related quality of life using LVQOL questionnaire pre and post LVA use during study period. Identify most effective types of LVA based on disease to analyze subgroup outcomes and conditions traditionally considered unresponsive to LVA. Material and method: place of study was low vision clinic at RIO IGMS. Period of study was 3 months. Data collection from the clinic RIO IGMS. Statistical analysis was done. Inclusion criteria: it included BCVA worse than 618 but equal to or better than light perception in the better seeing eye. Exclusion criteria included patient with multiple ocular conditions were excluded from the study if a single underlying cause could not be determined. Methodology: detailed ophthalmic evaluation was done using BCVA, disease-specific diagnostic confirmation was done, trial of appropriate low vision aids for near vision and for distance was done, follow-up was done with repeat BCVA and LPQL scoring. LPVA questionnaire, it consists of 4 domains in which distance vision, adjustment, reading and fine work and activities of daily living is included. This is a sample of the questionnaire which we were giving to the patient, and this is the interpretation. Minimal impairment more than 85%, 65 to 85% is moderate impairment, and less than 65% is severe impairment. These are the low vision clinic aids available in the RIO. Outcome measure was primary, change in LVQ score pre and post LVA. Secondary was change in BCVA. Exploratory was response in cases with profound vision loss. The result was significant, statistically significant, indicating a strong positive impact of LVA. Etiology of the vision impairment, most common cause came out to be retinitis pigmentosa. Change in visual acuity after LVA use. The chi-square shows statistically significant change in BCVA distribution. Patient with severe vision loss showed significant improvement post-intervention. Devices used across diseases. Dome magnifier was the most commonly prescribed LVA. Stand magnifier and LED magnifier also saw widespread use. Exceptional outcome cases responded well to simple aids like dome and LED magnifier. Telescopic aids were also given. Disease-wise pre and post LVQ score. Even visually debilitated groups showed meaningful psychosocial and functional improvement. Macular dystrophy had the highest post-QL jump. Disease-wise pre and post BCVA. LED magnifiers and dome magnifier help enhance residual peripheral or parafoveal vision. This suggests LVA can be tailored successfully for maculopathies. Contrary to the theoretical expectation, a small subgroup with BCVA as low as PL to CF showed significant functional quality of life improvement using LVA. Even in non-responsive groups, subjective and functional improvement were captured via QL score, highlighting the holistic value of rehabilitation. This study challenges the outdated notion that vision loss is equal to vision hopelessness, especially for PL hand movement, counting fingers vision levels. These are my review of literature. WHO reiterated the same thing, the need for vision rehabilitation service to be integrated into national health system as a fundamental part of universal eye care. Our study is comparable to India's Sarmaj and Rao that conducted a cross-section study at a tertiary eye care center and reported that 71% of patients using low vision aid showed marked improvement in near vision tasks. Low vision aid can be transformative, not just in improving best corrected vision, but in restoring confidence. Patients with ultra low vision, traditionally considered non-rehabilitable, can also experience functional and quality of life gains. Personalized selection of aids and patient counseling are central to success. These are my references. This study wasn't just about numbers, it was about giving 130 people a chance to read, to recognize, and to reclaim life. Thank you.
Thank you, Dr. Tiwari. Any question from judges?
Just a comment, I mean, it was a very nice study, and recently I also incorporated LVA into my practice, and we have seen the transformative change it can have. So you have very clinically and scientifically you have brought out that point. So nice presentation, thank you.
Wanted to add one point that I'm here on to your right side. In general, when you pick a topic for presentation, it usually is a very clinical topic or a surgical topic. I'm just glad that a youngster like you has picked a topic that a lot of us don't pay attention to, but is still very important from the point of view of not just vision, but the overall quality of life of a patient who can't see very well. So very nice that you've done that, and good study. Thank you.
This MTC is dedicated to Dr. Ashwini. He was probably pioneer in Bihar for this low vision aid. I would like to have comment from Dr. Dwivedi. He is also practicing low vision aid.
Doctor, regarding this low vision aids, I think Dr. Ashwini has started a wholehearted muhim, I think in Bihar. I think nobody was practicing, even I will say not knowing at all. So he was the person who made it to the level of awareness in Bihar, and now I think there are many upcoming centers which are working on that one. Definitely IGMS is one of the pioneer in that segment. And regarding this data and the study, definitely sir has already pointed out it's out of the box, and you have done a tremendous thing. So there are a lot of patients. I think we should appeal to our ophthalmologists that whenever they find in our criteria where the vision is defined as a low vision, they don't say that nothing can be done. They can get these magnifiers. They can refer to the hospitals where they can get the improved quality of life for this patient.
Thank you so much, sir. And with that, we will move to the last presentation. Sir.
Good morning, I am Samanta. When we are remembering Dr. Oshini this morning, and at the same time low visual aids, our Association of Community Ophthalmologists of India has conducted all over India all meetings with the theme low vision aid. But unfortunately, in many places we have seen not more than 1 or 2 speakers are available. But I must congratulate and always remember Dr. Oshini, who has taken up beyond this all handicapness, physical handicap, this low vision aid. And what I can just remember and like to express my all comments before you, that about 6 years back, when Oshini joined our mission of community eye health care in Bihar, he asked me, Dada, just tell me on which topic I can do some field work. I asked him, you just go on the roads of Patna and check the eyes of the cobblers and try to find out how many cobblers have got specs and what's the visual problem of the cobblers. He took it very sincerely. He went to the streets and corners of Patna city and examined each and every cobbler. And he has beautifully published a paper on ocular health of the cobblers of Patna city. And that was published in our journal, Vision and Mission at that time. Now it has been turned as Indian Journal of Community Ophthalmology. Such was the dedication of Dr. Oshini as well as for the visual aids. Thank you very much for giving me the opportunity.
Thank you.
Thank you, sir. We'll move to Dr. Prachi Singh. She is going to talk about explosive consequences, case series on firecracker injury at a tertiary care hospital.
Good morning, everyone. My name is Dr. Prachi Singh, JR1 RIO. My topic is explosive consequences case series on firecrackers injuries at tertiary eye care center. I have no financial interest, no conflict of interest. A firecracker ocular injury is a potentially serious trauma to the eye caused by fire or firecrackers. It peaks during festivals like Diwali and Chhath. Ocular involvement can lead to vision-threatening complications. Rationale of my studies, this case series highlights the spectrum and severity of ocular trauma caused by firecrackers. Aim and objective: to study the clinical profile, management and outcomes of firecracker-related ocular injuries, to evaluate preventable causes and raise awareness, to emphasize the need for protective strategies and legislation. Methodology: design of my study is retrospective case series. Time period is 2 months, from 1st October to 30th November 2024. Center of Studies, IGMS Patna. Departmental ethical clearance was taken prior to study. Inclusion criteria: all patients regardless of age presented to the RAO emergency and OPD with history of firecracker injury. Exclusion criteria: patient unwilling for examination or intervention, patients refusing consent for inclusion in study. Methodology: all patients coming to RAO OPD and emergency with firecracker injury were enrolled, consent taken for further evaluation and management. It was ensured that the patient's vitals were stable and patient was oriented to time, place and person. Active bleeding, if any, was attended at first. Thorough history was taken. Vision was recorded at the time of presentation in all cases. Visual prognosis explained to the patient and attendants in their local language. Written consent for inclusion study was taken. Demographics: the data of 22 cases of firecracker injury which presented to our RIO were recorded. Gender distribution was 17 males to 5 females. Age range was from 4 to 40 years. Mean is 22 plus minus 9 years. The youngest case that presented to our OPD was that of a 4-year-old male, child. Laterality: 16 unilateral, 6 bilateral. As you can see in the graph, 10 to 20 years of male are most commonly affected by firecracker injuries. Child injuries, innocent onlookers, adults, experimenters with explosive firecrackers, most common firecracker missiles, rocket. Types of injuries observed, 13 closed globe injuries, 9 open globe injuries. Closed globe injuries were treated most conservatively, open globe injuries repaired by primary or secondary repair. In closed globe injuries, 38% was constituted by hyphema, 31% by corneal abrasion, 15% by lead abrasion with ecchymosis, 8% by iridodialysis and posterior subluxation of lens. In open globe injuries, 44% was constituted by globe rupture, 33% by corneal laceration, 22% by globe rupture with IOFB, intraocular foreign body. In closed globe injuries, skin burn at medial canthus, periorbital edema and corneal erosion case was presented at our RIOPD. Traumatic hyphema, traumatic iridodialysis, cataract with zonular dehiscence, posterior subluxation of lens, IOL drop with vitreous prolapse in AC and secondary rise in IOP. In open globe injuries, corneal lacerations, which were salvageable, globe rupture, and retained intraocular foreign body. Visual outcomes. Final best corrected visual acuity at 2 months were recorded. 8 patients had 6 to 6 to 6 by 18 visual acuity. 6 patients had 6 by 24 to 6 by 60 visual acuity. 3 patients had then 6 by 60 visual acuity. 3 had no light perception and 2 were lost to follow. In our case series, 77 were males and 54% were children less than 18 years, similar to findings by Sharma et al., who reported male 78% and children 62% are most vulnerable due to reckless handling and poor supervision. Injury spectrum, the most common injuries, closed globe injuries, hyphema, corneal abrasion, and open globe injuries, globe rupture, corneoscleral tear. This spectrum correlates with Ashok Kumar et al. Closed globe injuries accounted for 60%, while 25% were open globe and 15% were mixed pattern. 2 cases of intraocular foreign bodies had guarded prognosis despite prompt removal. 1 case of globe rupture resulted in evisceration. According to Suhasini et al. 2017 aims, globe rupture and intraocular foreign body carry high risk for endophthalmitis, retinal detachment, and permanent visual loss. Lack of eye protection was universal. Bystanders significantly affected, highlights need for public awareness. Bottle rockets caused more severe damage. Delayed presentation worsens prognosis. Importance of early intervention and proper triage is required. Conclusion and call to action. Collaboration between the government, healthcare providers and the community is required. Stricter laws and ensuring regulations. Awareness. Increase public awareness on the dangers of improper firecracker usage. Organizing educational campaigns. Safety first. Prioritizing safety and measures like use of polycarbonate glasses, bursting safer, non-explosive, eco-friendly firecrackers. According to a study by AIMS Delhi, the national capital records around 76 firecracker-related eye injuries each year, mainly after Diwali. The study titled Prevalence of Firecracker Injury and Outcomes analyzed the demographic profile and outcomes of affected patients visiting a tertiary care emergency department. The findings underline the importance of comprehensive preventive strategy and public education to reduce ocular injuries, particularly in vulnerable regions like Bihar. My references. Take-home message. Fireworks-related eye injuries are a significant cause of preventable blindness, particularly among children and young adults. Early and appropriate treatment is crucial to minimize the risk of long-term vision loss. Prevention through public awareness and responsible use of fireworks is paramount. Thank you.
Thank you, Dr. Prachi. Timely finished. Any question from judges?
Yes, sir. Nice presentation, Dr. Prachi. The point you brought about, raising awareness about these things is very pertinent. One thing me and Dr. Chala were talking about, that you've not scored your cases. There are specific trauma scores.
Did you score and OTS scores.
Did you thought about doing them and prognosticating these cases?
Yes, sir. I should have done that, sir.
Okay. So that should have been done. It should have been an important part. Yeah.
Dr. Praveen, sir.
No, nothing further to add. I think nicely summarized, nicely brought out from the point of view importance, but also would be good to focus on little more of preventive measures, because I think that is something that is eminently preventable. Thank you.
Thank you so much, sir. And with that,
thank you everybody, all chairpersons, all judges for cooperating us to make it a success.
thank you, sir. Thank you, Vibhuti sir, Ashish sir, Amresh sir, Rungta sir, Manoj sir. Next, handing over to Gyan Bhaskar sir for the oration.
Again, good morning everyone. Now we are going to start our prestigious Dr. R.S.P. Sinha oration. For this oration, may I request our chairperson, President Dr. J.J. Agarwal sir, please come on there, sir. President, immediate past President Dr. Pradeep Karak sir. Past President Dr. Pranav Ranjan sir. President-elect Sunil Parmar sir. Not here. Vice President Subhash Prasad sir. Subhash Prasad sir. Our Secretary Dr. Satyajit Sinha sir. Treasurer Dr. Ranjana Kumar ma'am, please come. And Member Chairman Scientific Committee Dr. Abhishek Ranjan. Today Dr. R.S.P. Sinha is was born ठीक है sir. This oration is this time awarded to our excellent orator Dr. Praveen Krishna Vadavali. He is currently the direct head of L.V. Prasad Institute, Hyderabad, and it also serves as a director of Sandital Shavangi Cornell Institute and Institute of Excellence program of L.V. Prasad Institute. He has completed long-term fellowship program at L.V. Prasad Institute in the cornea and interest segment, and I went to join as a faculty of L.V. Prasad in 2005, and he has over 130 peer-reviewed and index publication and over 600 presentation, and has contributed to the leading textbook, and also is a founder member of Cornell Society of India, and earlier served as a founder chairperson of the Chairman Scientific Committee. So may I welcome Dr. Praveen Krishna to for the oration, deliver the RSP Sinha oration. Welcome, sir.
As the President, I invite, and we are happy to welcome Dr. Praveen Krishna, who is from L.V. Prasad, Hyderabad. He needs no introduction. Now we are happy to invite him for RHP Sinha oration. He has come from Hyderabad in this remote city of Bihar. Though it is a very old city, but we are very thankful that he took too much of pain to come from all the way from Hyderabad to this city of Sasar, Bihar. Thank you, sir. Now, just
पीछे जो लोग ट्रेड में हैं, पीछे जो लोग ट्रेड एरिया में हैं, आपसे स्पेशल निवेदन है कि ओरेशन के समय कृपया एकदम शांति बनाए रखें. एक ही हॉल अवेलेबल था, इसलिए एयर कंडीशनिंग के लिए हमको इस हॉल को 2 भाग में बांटना पड़ा है ताकि आप लोग को सहूलियत रहे. लेकिन आप लोग से फिर से निवेदन है, कृपया एकदम शांति बनाए रखें, प्लीज. थैंक यू.
Well, with that, I'd like to start, but before I like to start, first of all, thank you for the Bihar Ophthalmology Society for thinking of me as worthy of the oration and for inviting me. It's not a pain, it is a pleasure to come here, sir. Thank you very much, and witness all the wonderful work that a lot of you are doing, because I think from afar it is very difficult to understand the challenges as well as what you have done so well over the last several years. I think also very happy to acknowledge thanks to Dr. Gyan Bhaskar sir as well as Dr. Satyajit Sinha for also initially contacting and asking me to come. Dr. Abhishek Ranjan as well as other friends in the audience, Dr. Rashmika, Dr. Ashish as well. Nice to see everyone after quite a long time. So again, without spending too much time on formalities, again, I was just reading through the profile of Dr. R.H.P. Sinha sir, and I realized that he actually was from Ranchi. And the fact that you have somebody from Ranchi still as a named oration for the BOS even after the Slater split talks about the amount of impact that he's had over all these decades. So I think I'm very proud to be able to give an oration on his board. What I'd like to share with you today in the next 25 minutes, maybe 30 minutes or so, is a new way of looking at cornea care and corneal transplantations using technology and not just new techniques of surgery. And I want to present to you a sort of a plan that is developing and that probably will come to fruition in the next couple of years and is very, very exciting, not just for us at LVP, but for us as part of the whole country. So very briefly, going back in time about the history of corneal transplantation, there are three main phases of how corneal transplantation developed. When people started experimenting with tissues that can be transplanted in place of an unclear cornea, versus when people started setting up eye banks and initially started doing the first kind of human transplants, to now where you have modern transplantation and a lot of lamellar surgeries that are done that have excellent outcomes. Now, a patient after a corneal transplant that you see on the left side of the screen can have an outcome what you see on the right side of the screen after minimally invasive transplant surgery like DMAC. And these are surgeries that give vision restoration within a week to patients, very similar to cataract surgery right now. But then on the other side of the spectrum, we also have patients who don't do very well with corneal transplants for several reasons. So what is the reason why this is so? And I'll take you back to your attention to this interesting map that has been published several years ago by Sightline that shows us the distorted burden of blindness in our country. Because of the amount of blindness that we have, we actually have the most amount of burden of blindness compared to even countries in Africa as well. So what will it take for our patients to be able to achieve clear corneas like this and to be able to say that we've been a successful country in the area of corneal transplantation? Again, I'd like to take you back in time, and somewhere in the middle of last year, we achieved a milestone at LVP where we were able to complete 50,000 corneal transplants since the time we started. Now this is interesting because this is the highest number done by any single institute anywhere in the world, and given our difficulties and challenges in our country with retrieving corneas and people donating eyes, I think that number took a lot of hard work. There is a number of people behind that hard work, including all the members of the cornea faculty, and also a number of people in the eye banking area who were able to retrieve corneas for us to do so many transplants. What is interesting in this is the fact that the transplants that started in 1987 that you see on the left side of the screen, with 3 transplants in the first year and tissues imported from the US, now we average about 4,000 transplants per year, and we collect about 12,000 cornea tissues in a year and are able to distribute those to surgeons who require them even outside the institute. Majority of the transplants are full thickness transplants, quite a lot of transplants for infection, but also a number of transplants for lamellar surgery that we are doing right now. Patients are coming from all across the country. In fact, this is a map of all the patients who we've done corneal transplant for in 2023. So you see that they're actually spread all over, and a lot of people are benefiting from those services. The commonest reason why we do transplants right now is still infection. Second most common is endothelial disorders, and the third most common is repeat transplants. Keep in mind the repeat transplants as the third most common reason why we do transplants, and I'll tell you why that is important. But there are a number of challenges in the area of corneal transplants. There is a problem with affordability. Most patients are not able to afford the cost of a cornea coming from an eye bank. Tissues are not easily available because we don't collect enough tissues. Access to care is also getting better, but still is a major issue right now. And then once we do all of this, accountability on part of the patient, that is, you do a transplant, I think we were talking in the morning, that they disappear and they don't come back for follow-up. That is a major issue that we are facing as well. So how do we actually take care of that? So we thought that we'll actually approach this in a 3-pronged approach. So first we thought we'll try and reduce the need for doing corneal transplants by treating diseases like infections that result in scars that require transplants, by trying to identify them early and treat them before they result in very bad scars. Second, we thought we'll work in the area of eye banking to try and increase the supply of corneas that are available. And third, like I said earlier, we'll try and sustain the corneal transplants that we are already doing so that they don't fail as early as they're failing right now. So we put together a multi-pronged approach, and you see at the center of all of this is corneal transplant. Everything in yellow are all the strategies to sort of prevent patients from requiring corneal transplants. All the ones in green are the strategies around eye banking, and the ones in blue are all to prevent failures of transplant. I'll get to this a little more in detail now in the next few minutes. So what we did was we went back and got our data out from LVP, and we classified all the cornea patients by the type of disease they had. And we started to put together individual programs for each of these diseases. The first one that we actually looked at is where these patients are coming from also. The green color bars are all the patients who are coming from rural areas. The blue and the red are the ones coming from urban areas. So we are customizing the programs we are putting together for patients coming from rural areas versus patients coming from urban areas, because the same thing won't work for both. So what we are trying to do, for example, is in ocular surface disease, say for example in patients who have ocular surface tumors or ocular surface pathology, or even simple surgeries like pterygium amniotic membrane graft, we are now trying to set up remote online coaching sessions for doctors who are posted in rural areas to teach them the correct technique of how to do these ocular surface issues. And also because ocular surface issues are very visible in front of the eye, we are also setting up, we have actually set up teleophthalmology command centers. And these command centers are located in our rural eye clinics. These are all in villages in the 3 states of Telangana, Andhra and Odisha. Patients come to this clinic and then they get a teleconsultation with the doctor who's sitting in Hyderabad. And if they can recognize what the problem is, like a foreign body, conjunctivitis, or maybe an injury to the eye, the doctor then gives them advice on the phone what to do. And about 85% of patients that you see in green here, we are able to treat online, and only 15% of them actually need to be brought to the hospital. So we are reducing the need for patients to travel to tertiary centers or get more complex care. The next disease that we wanted to work with is infections. So what we started to do is, like earlier in the previous session, like Dr. Rangta was saying, we don't have access to corneal scraping in many of our centers, which is true. So what we started to do is we started to buy these microscopes. Like I said, not very expensive, about 10,000 rupees. We fitted the microscope with a camera. And now all the scrapings that are done in the rural centers, photographs are taken of the slides of all of these, and then they are uploaded onto the patient's medical record. The microbiologist who's sitting in Hyderabad, connected to 10 centers around her, then looks at all the slides and gives a diagnosis whether this is bacteria or fungus, and then tells the doctor that this is the diagnosis, and they're able to start treatment appropriately. In addition to that, we've also set up slightly more advanced microbiology facilities in 2 of our rural centers that include culturing and also sensitivity profile of these organisms, and these are in villages, remember, that did not have any access to microbiology earlier, and it is not very expensive to do that. In addition to that, all of these images that we are collecting from the rural centers, we are actually training an AI algorithm to be able to detect the pattern of the organism on these images, so that in the future, you might not even require a microbiologist, and just using AI, you'll be able to get significantly good results from the point of view of being able to identify these organisms. As of now, the accuracy of identification is about 87% by this AI model of just looking between the different kinds of bacteria, and we hope this will get better as we train it. Another very interesting thing that we have started doing in the rural areas is we are giving this little attachment to a mobile phone to patients. This is just clipped on to mobile phones, costs about 40 rupees, and then patients can take photographs of their eyes. And once we are taking photographs of their eyes, we are also developing an app on a mobile phone that will be able to detect infection And once it detects infection, it also is able to detect whether the infection is caused by bacteria or it's caused by fungus. All of us know that 90% of the infections that we have are caused either by bacteria or fungus. And if you are able to differentiate 90% of our infections, we'll be able to start targeted therapy much earlier than we are doing right now. And in addition to this, what we're also doing is the same app is able to take photos of the patient eye, and it is using AI to tell us whether the infection is improving or it's getting worse. If it is improving, then the patient is continued on the same medication. If it's getting worse, then he's referred to a higher center for maybe a biopsy or more scrapings. Now, this model has given us almost 90% of accuracy in being able to detect different organisms just using a phone camera and one photograph of the cornea. So this will probably put microbiologists out of business in the next couple of years. Where we are at right now, we've got about a 90% success in being able to detect an infection, and we are now working on the model to improve the accuracy in being able to detect fungi and bacteria from a slit lamp photograph. The third thing that we are also doing is we are trying to detect keratoconus. Now remember, all of these are diseases that potentially require corneal transplants, so we are trying to detect them early and treat them early. And all of us know that the keratoconus load has increased quite significantly in the last several years. And we also know that the average age that keratoconus occurs is somewhere in high school. So unless we go and detect these children early, rather than wait for them to come back to the clinic, we might not be able to catch them early. So what we are doing as part of our program is we've got a bunch of pentacams, because they're the gold standard for topography. We are taking them to schools and we are screening children using these pentacams, as you can see here, and then we are trying to detect keratoconus. And interestingly, we are finding about 3 to 5 children with undetected keratoconus out of every 100 that we screen. So imagine that if you are able to detect them early and provide them cross-linking, you will probably be able to save about, and these are all 15-year-olds, save about 50 years of visual disability that might have. And that is the importance of being able to detect them early and also to prognosticate them early. What we are also doing is we published a report earlier on how we can detect keratoconus early using an AI algorithm. And we are also now feeding this AI algorithm with topography scans from these children. And this is able to tell us which of these children will progress and become worse with time, which of them won't progress. So we're able to make decisions about collagen cross-linking right at the first visit without having to wait for follow-up and looking for progression in the future as well. This AI model is KeraPro. It's called Keratoconus Prediction Progress Model, and this is something that will be available for use somewhere in September and October or so. So we've completed about 50 or 60% of the work on this model, and it should be available for public use in about September or October. Another interesting area that we are also working on is trauma. And all of us know that in medical colleges as well as clinics, one of the most common reasons that patients come to us is because of eye injuries. And as residents, all of us did eyelid tear repair or corneal tear repair in our OTs, but then we probably didn't do a great job. So we are also trying to see if we can channelize all of these eye traumas that occur probably across the state into 1 or 2 trauma specialized centers that are trained to manage trauma patients, not just eye trauma, but also systemic trauma. And we're trying to partner with the GVK EMRI Health Services, which run the 108 ambulance services in about 13, 14 states right now, and trying to use the same call center and the same system to channelize eye traumas to specific locations. Now the second part of what we're trying to do is in the area of eye banking, and you might find this quite interesting because one of the reasons why I'm here is also to look at our friends at AIMS Patna who started an eye bank, and following that the eye bank at RIO Ranchi that we've also helped establish. But again, this picture presents a relatively sad story of eye banking in our country. So we have about 165 established, registered, active eye banks, of which 13 of these eye banks are responsible for collecting 70% of all the tissues in the country. And if you add the next 11, that is the 24 out of 165 eye banks are responsible for collecting almost 90% of all the corneas in the country, which means that the remaining 145 or so are not really functioning very well. So the current scenario is that we collect about 50,000 corneas across the country and we use about 30,000 of them. But we need to collect at least 1 lakh corneas per year to be able to meet the demand of transplants, and we need to increase the utilization to at least 60,000 per year to be able to make sure that we take care of all people who need corneal transplants. So what are we doing about this? So we are doing a complete rework of the eye banking system using technology. The first thing that we are doing along with a company called Infosys, all of you are familiar with Infosys, is something called iPledge. Nowadays, whenever somebody wants to pledge their eyes, what do? They go to the eye bank, they fill up this form, they sign on the form, and then they give it to the eye bank. And the eye bank stores it in their cupboards and nobody looks at it for decades because there's no trigger for them to look at it. What we're doing instead is using an app called Sight Connect. You can download it on your phone right now if you want. We are actually linking this to the patients or the donors or the person who pledges ABA number, not their Aadhaar number, but their ABA number. So that in the future, whenever this person passes away, there is a link to the ABA number to the hospital that he passes away in, and there is an alert that comes to the eye bank in the region saying that this is a potential donor and you can go and collect eyes. And at the same time, the person is able to nominate his family members about his wish to pledge his eyes. So when he passes away, they also get notifications saying that, hey, now don't forget about the fact that your family member had pledged his eyes. So we believe that this will also increase the awareness of eye banking. It will also increase the number of people who will sign up as donors, and it will also complete the circle for eye donation in the future as well. And we hope that that will be a problem in a country like ours that we'll be able to mitigate. This is available online as an app on the App Store as well as the Play Store. The iPledge feature will be launched during the eye donation fortnight in a couple of weeks from now. Another interesting thing that we also did was we did a survey of all the cornea surgeons in India. There are about 1,000 members of the Cornea Society of India, and we asked them, why aren't you doing enough transplants? So about a quarter of them said affordability, a quarter of them said they don't have access to corneal tissues. So what we thought that we should do is we started building a module, like an EMR for hospitals and for patients. We started building an EMR for an eye bank. So what we did was we built the entire systems of operation of an eye bank right from the time that they get a death notification to processing the tissue, to also onboarding the tissue and putting that in the inventory online so that they could run everything from a tab that they're holding in their hands or even from a mobile phone. The advantage of this is the fact that once you have several eye banks come together and several eye banks are able to process their eye collection, processing their entire operations, there also is a matching system that we're developing in the back end that is going to be able to match these corneas using AI again to potential recipients in the future as well. And another problem that we found in eye banks is the fact that about 100 eye banks in the country did not collect a single tissue in the last year. They only are eye bank in name but not in function. And when we went and tried to work with them, we found out that one of the main reasons they're not able to collect tissues is because they don't have good human resources to be able to grade the tissues and then distribute them. So what we thought we'll do is we started building another AI model which relies on the images that are taken from donor corneas and from the specular. And we are training the AI model to be able to automatically grade tissues so that it can decide what type of surgery, what tissue will be useful. And if this system can replace the HR in some of these eye banks, we believe that these eye banks will become better functional in the future as well. So in addition to that, what we're also doing is we're trying to install these Site Connect apps or these digital systems in some iBanks in LVP and hopefully with other partner iBanks as well across the country. And eventually, what we would like to do is make these excess corneas that are available as part of a cornea distribution system that will be available to any surgeon anywhere across the country. So in some ways, this is going to be the Amazon of iBanking, where all the tissues that are available in this group of iBanks will be listed. All the patients registered for iBanking will be listed on another site. There is a back-end matching algorithm that will be run, and there'll be matching for corneas to recipients, and the complete operations, including delivery of the corneas and tracking of the corneas, will be run through a mobile app, hopefully in the future as well. And we believe that access to corneal tissue will become much, much easier for surgeons anywhere across the country too. Now the last part of what I spoke to you, we're doing all the hard work, doing the transplants, but is the patient actually keeping his end of the bargain? So we realized that even at LVP, about 50% of our patients don't come back for follow-up at the end of first year after transplantation. So what we started wondering is why don't they come back? And we started looking at the factors that prevent them from coming back. And we realized that about 50% of our patients live more than 200 kilometers away from the hospital. So distance is a major factor. So we started a project, very interesting project called Project Sarathi, which is going to enroll patients and make sure that they don't drop out of follow-up. And this includes several components. It includes Community Eye Doctor Connect. So the patient as well as their referring doctor are signed up on a mobile app, and then they can do everything on that app, including taking a photo of their eye. They can have a chatbot. They can also set up a teleconsultation so that they can consult with their referring doctor without having to travel every time. And their local doctor is providing them care and also ensuring that they look for any complications that occur. So this managed care includes a counseling team, which also has a call center. And patients, if they're dropping out of follow-up, we've been calling them actively, and we've managed to reduce dropout of follow-up from 25% to only 7% last year. We've also developed a WhatsApp-based keratoplasty chatbot, and this chatbot is multilingual, works in about 28 languages. And this chatbot, the patients can converse with. They can actually put in their symptoms, redness, pain, whatever. And the chatbot will analyze those symptoms and tell them that if they need to go in for a follow-up, if they need to go and see their doctor or not. And now we've also allowed the chatbot to take in pictures of the eye, and it can analyze the pictures, and the patient has like a loose suture or a graft infiltrate or an infection. It immediately tells the patient that I'm going to set up an appointment for you. You need to go for a checkup right away as well. And this is the picture of the Grabby that I showed you earlier. All the photos that we are receiving from patients post-keratoplasty, we are able to annotate and make them into a learning model for another AI model that we are building that we hope will serve as a remote automated teleconsult system for all patients having corneal transplants so that you can pick up complications earlier than what you're doing right now. The last part of this, again very interestingly, is we put in all the data from our corneal transplants at LVP over the last 38 years. And then we started to build a predictive model about which graft is not going to do well. Even before we do surgery, we asked, can we actually tell which graft will survive for how many days and which patient is likely to come back for follow-up? So happy to say that we've also been successful in building this AI model. It will be available again probably in October, which can tell what is the potential visual improvement in different patients, what is their likelihood of follow-up, and what is their likely duration of survival for the graft. And we're able to prognosticate what will be the journey of a corneal transplant in a patient even before we do the transplant, so you can take an informed decision about whether you should do the transplant or not. So that in summary was the challenges that we're facing with corneal transplants and our patients, but there are a lot of solutions on the way. And the reason why I say on the way is this is not just a project that is meant to be published in a paper. This is a project that has a vision of trying to reduce corneal blindness by at least 50% in the next 10 years. And to work with different partners nationally, because we know that sitting in Hyderabad, we are not going to be able to do this nationally. We can probably do it in our state. But if we have to really achieve this, then we have to put all of these programs together, and I put all of those programs together in this very complex slide. And we are trying to start working with some partners. In fact, we are having our first partner engagement meeting in about a month from now. And our timelines are, we have set up this project in Jan 2025. We are going to continue till March 2026. After that, for 4 years, we are going to work with different partners. Anybody of you here as well is welcome, and we're going to work with them, offer them the use of all of these algorithms, all of these platforms that we are building, so that you can leverage these for the care of your cornea patients as well. And overall, together, we can probably elevate the level of corneal transplantation and eye banking in the entire country as well. In fact, we are having a first partner meeting with some of the largest eye hospitals in the country right now in about a month. Later on, we believe that we will be able to spread not just from the southern and the eastern part of the country, but also to the north, the central, the western, as well as to the eastern part of the country with the partners that we've planned. So I'll end there because I just wanted to share with you what is the blueprint of this very exciting project that we call Project Clear, meaning that it is a project that is meant to achieve clear corneas. This is in collaboration with Infosys Foundation, and hopefully in the next 5 years or 10 years or so, I'll be able to come back to your society and share all the success that together we've been able to do in the area of corneal transplantation in the past 10 years. Thank you very much again for the honor.
This is absolutely huge. This is an amazing work.
Very good presentation. As I am interested in AI, in ophthalmology since last 10 years, but your presentation and your work in LBPI is excellent. I think that in the next coming years, you will provide the opportunity to all of young ophthalmologists to diagnose the corneal ulcer and its prognosis and how it will be recovered in the present time. Not only the corneal ulcer, you have also guided us around for the keratoconus, which early diagnosis is very important, which is very difficult in our areas. And your AI algorithm will help you diagnose the early. And lastly, the corneal transplant. In the year 1986, 88, 1890, we have done total corneal transplant in Aligarh, Gandhi Hospital, Aligarh, and the Institute of Ophthalmology. At that time, the cornea comes from the Haridwar or from the Banaras. But after that, it has been just postponed due to your corneal opacity. Now, your AI algorithm will help us when what cornea is important, or what corneal tissue is fit for that patient, and it will help us that what type of cornea you will implant in that particular persons. Thank you for a very good presentation, and I hope that your amalgamation of AI with the cornea will be great helpful for us in future. Thank you.
For the devotion and the dedication of Dr. Praveen and his team, may I request everybody to please give a standing ovation to the entire team who is doing an amazing work at LV Prasad and motivating them. Since Dr. Praveen will be leaving, he won't be available for the... Please be seated. Thank you. Since he won't be available for the inauguration, conventionally we give it during the inauguration, the Oration Award. But now, since he has to leave, I'd like to request Dr. Praveen to please take the chair of honor. And we would like to request our president, Dr. J.G. Agarwal, sir. Don't break apart. To please give the shawl of honor. I'd like to request our President-elect, Dr. Subhash Prasad, to please give the oration medal to Dr. Praveen. I'd like to request immediate past President, Dr. Pranav Ranjan, please better. You have to sit on the chair of honor to give the certificate. And finally, I'd like to request again our President, Dr. J.G. Agarwal, sir, and the Chairman Scientific Committee to please give the... So, नीचे रखना होगा, नीचे कीजिए, हाँ नीचे रखना. Yeah. Please come in. जरा स्क्रीन ऑफ कीजिए तो हरी जी. स्क्रीन ऑफ करवाओ. हाँ ये. Thank you so much. Dr. Praveen, just for the record, there are 7-8 centers which are doing corneal transplant here, including at Division Dr. Subhash Prasad's place. RIO AIMS is doing an amazing work under the leadership of Professor Vibhuti and Dr. Nilesh Mohan. They have done thousands of PKs. Ashish is doing a lot of amazing work. Rashmika is doing a lot of amazing work. And am I missing anybody who is doing cornea work? Abhishek Kediyadar, Ashish Kar. Oh, sorry. Sorry. Abhishek Ranjan is doing amazing work. So I didn't want to miss out anybody. That's why I just surrender and ask. And Dr. Ajit Dwivedi, Patna Medical College Hospital is also doing amazing work. Dr. Soni Sinha is doing amazing work. NMCH is also doing. So we have 7-8 centers which are doing corneal transplant, and they'll be in touch with you for the amazing work that you are doing. So thank you very much once again for traveling all the way from Hyderabad. We are very, very grateful to you and very indebted. Thank you so much.
I request the moderator of next session, Dr. Abhishek Anand is there. Dr. Abhishek, Dr. Sujata Kumari, Dr. Sujata, Dr. Abhishek Kedia. May I request the chairperson of this session. We are going to start the expert corner session. May I request Dr. Abhishek to conduct this session.
May I request the chairpersons for the next session, the expert corner, Milind sir, Dr. Milind sir, Kanhaiya Singh sir, Sudhir sir, Nageshwar Sharma sir, and Sunil Singh sir to occupy the dais. Sudhir sir, please come on the dais. Nageswar Sharma sir. Sunil Singh sir. Kanhaiya Singh sir. Dr. Sujit Misra, please come on the dais. Ranjana ma'am, please come on the dais. Dr. Santosh Misra, Dr. Santosh Misra, Dr. Deepak, the conveners for the sessions are Dr. Vishal Kusor, Dr. Kunal and Dr. Rakesh and myself. The keynote address for the session is by Dr. Divakant Misra, and he'll be speaking on recognizing which retinal pathology needs which anti-VEGF, a general guideline in your routine practice for non-retina specialists. And Dr. Divakant is the current president of Young Ophthalmologic Society of India, and they are doing amazing work at EOC. May I welcome Dr. Divakant.
Thank you so much to the whole leadership of Bihar Ophthalmic Society for giving me this opportunity. May I have the slides, please? Yeah. So I'll be talking about, a very pertinent topic in these days about identifying which retinal pathology needs which injection. So a lot of, people are injecting these days, so it will be a good idea to have a basic guideline how to go about. So just before we come to the clinical part, just imagine that one fine day, Mr. Amitabh Bachchan, who has everything in the world, walks into your clinic with an OCT like this, let it be a vein occlusion, be diabetic retinopathy, comes to you asking for an injection. Just hold on to that thought, and with a similar scan, Mr. Manoj Bajpayee, from his role in Family Man, a person in job, comes seeking an injection for the same pathology. And if somebody like Mr. Nawazuddin Siddiqui, who's known for his, low-profile roles, and what if this person comes to your clinic asking for injections? So I'm sure the answer for all the three patients will not be the same. So what I'm trying to tell is that, science is in one place, but when it comes down to taking a decision for your patients, a lot of other things do matter. So we'll come back to this later. Now, coming to the injections that are available, we have a plethora of injections in our basket these days, from 2004 when bevacizumab was there, till today when we have newer injections like faricimab, brolucizumab, and aflibercept in our armamentarium. Now, when a surgeon, a physician, a doctor chooses an anti-VEGF injection, apart from the financial aspect which we discussed earlier, there are other things like how the drug works, what do the RCTs and what the real world data tells us, and what our own experience guides us. So these things help us in coming up to a decision. Now all these injections, ranibizumab, bevacizumab and brolucizumab work on the VEGF pathway. Aflibercept also works on PIGF, and the newer molecules like faricimab has a dual pathway which involves the Ang2 pathway. All of these things collectively work on inflammation, vascular permeability, and reducing neovascularization, working basically towards the same goal. There are various indications these days. We'll just discuss select few. We'll be discussing wet AMD, diabetic macular edema, and vein occlusion. So coming to edema, it is a very complex disease. A lot of, I'm sure everybody knows about the pathophysiology of these diseases. It's important to know that, now we do not use the terminology CSME. It's mostly, slit line biomicroscopy finding. We are more focused on the OCT finding of center involving and non-center involving DME. I'm sure everybody knows about that. before 1980, we did not have any treatment. Since 1980s, we had laser photocoagulation followed by low-cost steroids, and since 2012, we have been very lucky to have anti-VEGF therapy in our basket. But now in 2025, it is more about using all of these things to optimize treatment for your patients. When discussing about DME, I think it is very important to focus on the systemic control. All your treatments fail if that is not there, and the treatment that the doctor does is more focused on VEGFs, injections, lasers, and steroids. If you want to learn this in a concise manner, this article in IGO is very useful. And this article for the Indian population has specifically said that anti-VEGF should be the first line of treatment for DME patients. Now, which anti-VEGF injections? There are a lot of protocols. I will not bore you with these protocols. We just need to know Protocol T, which had a head-on comparison between the most commonly used anti-VEGFs. Now, if you look at this graph, you will see that it clearly established the superiority of ranibizumab and aflibercept over bevacizumab. But if you look closely, aflibercept and ranibizumab were quite close, though aflibercept did perform better. So because of this reason, we take ranibizumab, either biosimilar or the original molecule, to be the drug of choice in these cases. So just to go through the protocol when you are managing DME, if a center involving DME case comes to you which has not taken treatment before, what is recommended even by Indian guidelines is to go for 4 to 6 monthly injections. In my practice, I do 3 loading doses. This is basically a loading dose regime, 3 loading doses, not 4 to 6, and then observe the patient. If you feel there has been resolution of DME, and there would be no further improvement, you can put the patient on observation and follow up according to your protocol which one is following. And if there is worsening or recurrence, then you can go back to the same anti-VEGF because you know that it worked the first time. But if in the first instance, after completing your loading dose, you feel that the response is not adequate, then it is classified as a persistent DME case, and it is, you need to switch to a different anti-VEGF or a different molecule overall. Similarly, if you get a non-center involving DME, then you can observe if the vision is good, think about lasers. If the vision drops, you can think about anti-VEGF injections as well. So a patient, when you have a non-responder or a patient who's not responding to injections, it's a time to move on, make a switch. So when to switch? Now there are certain criteria that will be laid out in different studies and trials. It is based on either visual acuity or the central macular thickness. If the vision gain is lesser than 5 letters or a vision loss of more than 5 letters, then you can switch. If there is the CMT reduction is less than 20% or there is a drop of more than 10%, then you can switch. And when you should not switch, protocol we told us that if there is still edema but the vision is better than 6 by 7.5, you can very safely observe these cases, keep them under follow-up and inject when the vision drops. Now, a lot of people ask after how many injections should we switch. Most of the trials and studies, they have switched after 5 to 6 injections. And in the real world data, it is mostly 2 to 3 injections. In my practice, I do also after 2 or 3 injections. Now, what to switch? Now, considering if you have used ranibizumab in the first go or bevacizumab, you should go to a better molecule. If it is bevacizumab, go to ranibizumab. If ranibizumab, you can go to aflibercept. If you are seeing certain signs, which we'll discuss later, you can switch to steroids as well, or think about surgery in very select cases. Now, these are some telltale signs of inflammation that are there. These large neurosensory detachment, big cystic spaces, hyperreflective dots, hard exudate plaques. This tells us the inflammatory load is more and you need to move to a steroid in these cases. So one case which I encountered this last week, so you can see hard exudate plaques right at the macula, large cystic spaces. This is the picture after 2 Ozurdex injections. The hard exudates are gone and the macula is dry. We also did put the patient on antilipidemic drugs as well. So there are certain indications for steroids. when the patient is not responding well to anti-VEGFs, a patient has had a heart or a vascular event in the last 4 to 6 weeks, patient is pregnant, a patient has been planned for cataract surgery along with DME, or the patient cannot follow up properly, then you can switch to steroids. Now, DME progresses very rapidly. Your NPDR can progress very rapidly to a PDR case after an eventful or even a non-eventful cataract surgery. So the recommendations that have been laid down is have good control when you are planning cataract surgery, do extend the cover of steroids and NSAIDs, and combine with some injection, either anti-VEGF or Ozurdex injection. I usually mix it with a Ozurdex injection along with the surgery. So there's a lot of data that is there that suggests that Ozurdex works really well in these cases. One last point about diabetes: if you see a case like this with a tractional component, do not inject anti-VEGFs. There is something known as a crunch phenomena, and these tractions can really go bad. It is better to laser them or refer them to a VR surgeon for further management. So in cases of diabetes, my go-to drug is usually a biosimilar ranibizumab these days. I switch to an Eylea if the patient is not responding, or if the patient is affording and is a treatment naive patient, I also start with, in lot of my patients, with Eylea. You can switch to Ozurdex, or if you see signs of inflammation, you can start with Ozurdex also in these cases. And if the patient is non-affording, Avastin is always there. A lot of people think that Eylea or aflibercept is very expensive. I did a cost analysis for one of my patients, a patient who had received 3 bevacizumab and 6 ranibizumab in the last year, had a total cost of 1,54,000 in year 1. And in the second year, when he was with us, we put the patient on Eylea with the patient support program, and the cost was almost similar. So I'll just rush through CNVM. Everybody knows the pathophysiology. There are a lot of studies like Tenaya, Lucerne, Hawk, and Higher trials. What these studies have told us, again, these have also established in the Indian population that ranibizumab should be the first drug of choice. My drug of choice is aflibercept in these cases. The dosage can be up to you, but mostly I follow a PRN dosing in these cases. Loading doses of 3 injections followed by PRN. Now, one thing that needs to be known, you can easily identify a case of PCV in these cases, which is marked by these tall peaked PEDs, these notch in the PEDs, a hyperreflective ring, or a double layer sign. And the guidelines now, the latest guidelines recommend that aflibercept is the drug of choice even for the Indian population in these cases. BRVO, CRVO, everybody knows about the clinical presentations. There is an interplay of VEGF, PIGF, basically VEGF and inflammatory load is there. So, a lot of these drugs work wonders. I would recommend not to use brolucizumab in these cases. A lot of inflammatory cases have been reported with these, but any other drug would do well. The LEVO study told us that aflibercept fared slightly better in these cases. Again, my drug of choice is ranibizumab, and I also give Ozurdex in treatment-naive patient in these cases as well. So just to conclude, that these intravitreal injections have been a game changer, but they bear a great financial burden to our patients. So we have to be very wise while choosing our drug and the regimen for that patient. I would recommend to identify these patients early and treat them very early and aggressively. In cases of diabetes, a good focus should be on the metabolic control, and do counsel your patients for multiple injections and for switching the drugs if needed. A lot of times patient comes to us that only a single injection was advised. Do counsel the patient accordingly, and do refer. I recommend that all ophthalmologists should manage medical retina, but please do refer whenever there is a doubt. Thank you so much.
Thank you, Devakant. Very well presented. So you have nicely explained. Here, Devakant. So very well presented, and you have nicely explained when to switch and which molecules to consider. So depending on the etiology and the pathology, we can consider. Just one question. Suppose a patient has undergone is supposed to undergo cataract surgery, and there is non-central involving DME, but encroaching fovea. Would you like to inject or just do a plain cataract surgery?
Yes, sir. I would always inject in these cases. As I said, there is very rapid progression of DME, I have seen a lot of cases progressing to very aggressive PDRs after an NPDR case, in another 3 to 4 months rapidly progressing to a PDR case. So it's always better to inject, even if you see some edema, do inject in these cases. Yeah. And my drug of choice, as I said, is Ozurdex usually, because after we see delayed edema in these cases after 2 to 3 months also. So Ozurdex gives us a longer coverage in these cases.
That's pretty right. But if the patient is not affording Ozurdex, we can also give anti-VEGFs.
Yeah, anytime. Yeah.
Dr.
Thank you,
Diva,
Diva.
Dr. Diva, I wanted to know what is the role of lasers in this era vis-a-vis anti-VEGF?
Sir, if you're talking about grid lasers and focal lasers for these cases, PRP I do very often for PDRs. That's a must in the Indian population. When tackling DME, I rarely do lasers now. Once in 3-4 months I go for, because the injections give a good coverage. But if you feel that the patient is a non-responder, the patient cannot further afford more injections, then it's a good choice to go ahead and laser rather than injections which might be costly for the patient.
You recommend any proliferative, you do lasers if it is possible?
Proliferative 360 degree PRP, yes.
Do for central, you do anti-VEGF you prefer?
Yes, I would prefer. For the proliferative component, it's always better to laser out. A good 360 degree PRP is very important. We cannot keep injecting.
Exactly.
Like my colleagues in the US, they go on injecting air on with anti-VEGFs. But
and what is your preferred time of giving intravitreal anti-VEGF for cataractous patients who is having DME?
Sir, in my practice, I inject it on along with the cataract surgery.
Along with the cataract surgery.
The guidelines recommend that either you can do it 1 week in advance, or you can also go back doing, if you are using Ozurdex injection, you can also inject 1 month in advance if you are planning the surgery. In my practice, I do it in the same setting.
Okay, thank you.
Thank you, Divakant. So, may I now request
I just
Dr.
wanted to
Abhishek
know
Ranjan?
that if you give a single injection and it dries out the retina completely, you would still stick to a second and a third injection for
Yes,
all
ma'am.
patients?
Yes, ma'am. Always. A loading dose for all my patients. Yeah.
Thank you, Divakant. So, may I request now Dr. Abhishek Ranjan to present on surgical strike in chemical injury. Abhishek has to rush with Dr. Praveen Krishna to Patna. So, may I request Abhishek?
So just a short message for all the juniors, students who are sitting at the back. The speaker just now was the president of the Young Ophthalmologist Society of India. It's doing huge and amazing work. If you want to become a member, he is the secretary, Dr. Nilesh, and Dr. Divakant is the president. Pan-India, just young ophthalmologists like all of you. They're doing amazing work. Congratulations, Dr. Divakant and Dr. Nilesh.
Just one announcement I'd like to make to all the PGs over here. We are having a iSiksha program. Sir is going to be there. It is in association with District Punjabi Hospital. And all the PGs who will be coming, we are going to give complimentary life membership of UC to all those PGs. So please participate.
Very good afternoon to all of you. I'm talking about surgical strike in chemical injury. No financial interest. Chemical injury is about 20 to 30% of all ocular injuries. It's if a corrosive substance is accidentally introduced to the eye or a particular tissue, it's called chemical injury. It is true ophthalmic emergencies that require immediate and intensive intervention to minimize severe complication and profound visual loss. So these are common offending agents. So in acute cases, we can see patient presents with periorbital edema and edema, depithelialization of skin, loss of eyelash and eyebrow, corneal and conjunctival epithelial defects, chemosis, conjunctival inflammation, limbal ischemia, corneal cloudedness, edema, and occasionally perforation. One of the most important prognostic factors for visual outcome is the extent of ocular surface damage, initially reflected by the amount of limbal ischemia. And accordingly, there are two popular classifications like Ropperhol classification, in which it's graded into 4 grades, and Duaz had classified chemical injury in 6 grades. So course of the disease is divided into 4 physiological stages, like immediate phase, acute, early repair, and late repair phase. In the immediate phase, we have to irrigate thoroughly with either with the plain water, or if in the hospital, you can use RL or basal salt solution. The main objective during acute phase is to decrease inflammation, avoid further epithelial damage and stromal breakdown, and foster reepithelialization. For anti-inflammatory effect, we have to use topical corticosteroid, which is critical in controlling acute inflammation and reducing the resulting inflammatory damage to the ocular surface after a chemical injury. The goal is to inhibit surge of neutrophil infiltration. For prevention of stromal breakdown, we can use collagenase inhibitors like tetracyclines, ascorbic acid, cysteine or acetylcysteine, and protease inhibitors like aprotinine and citrate. For promotion of reepithelialization, we can use frequent preservative-free lubricants and prophylactic antibiotic eye drops. Always avoid any toxic medicines. Bandage contact lens can be used. Other method is amniotic membrane transplantation, which is permanent surgical graft to provide a basement membrane for epithelialization and provides a biological bandage contact lens. So this is the method. First, we have to remove all the devitalized tissue, and we have to spread the amniotic membrane over the ocular surface. And if the damage is to such extent, then we have to include amniotic membrane, we have to include cornea along with the fornix and up to the lid margin. So these are the results. Other methods of promotion of reepithelializations are autologous serum and platelet-rich plasma. In severe injuries that causes loss of limbal vascularity and subsequent radiate segment necrosis, we can do tenonplasty. It helps in re-stabilization of limbal blood supply to and promote ocular surface repair. In this, all the devitalized tissues are removed thoroughly until we can get the vascular tenons tissue, and then we have to advance the tenons tissue to the bare area, and we have to fix it with the fibrin glue. Over that, we can use amniotic membrane also. In chronic phase, the goal of this surgery intervention is to restore normal ocular surface anatomy and visual function. The typical order for surgical intervention is correction of eyelid abnormalities, management of glaucoma, ocular surface reconstruction or transplantation, and keratoplasty. For fornix and eyelid reconstruction, symblepharon and ankyloblepharon are best classified as a form of conjunctival deficiency. In these cases, in mild to moderate, symblepharon excised tenons tissue and preserved conjunctiva. Fornix reconstruction with amniotic membrane and antimetabolites such as mitomycin C or fluorouracil can be used. For severe and extensive symblepharon, we can use mucous membrane grafts also. In limbal stem cell deficiency, management strategy is based on severity and laterality. For partial LSCD, we can use non-preserved lubrication, autologous serum eye drop, and topical vitamin A. While if central cornea is involved, then we can use sequential sector conjunctival epitheliectomy, amniotic membrane transplantation, and if all they were failed, then we can use ipsilateral limbal transplantation like claw or slit. In case of total limbal stem cell deficiency, we can use conjunctival limbal autograft, cultivated limbal epithelial transplant or CLET, and simple limbal epithelial transplantation like SLIT. So limbal stem cell transplantation is not recommended during active inflammation. So in Kraut technique, we have to dissect all the tissue, pannus tissue, and we have to remove the pannus, and then we have to do take conjunctival autograft from one side, and we have to fix over there. In simple limbal epithelial transplant, first we have to remove the pannus for all around 360 degree, and then we have to clear the cornea. Then amniotic membrane is spread over that. It is fixed with the fibrin glue, and then we have taken biopsy, limbal biopsy from other eye, and it is spread in a small pieces, and it is placed in the mid-peripheral area, and then bandage contact lens is applied. So in living-related conjunctival autograft, it requires performing surgery on two patients like donor and patient. It supplies goblet cell and transplant conjunctival carrier tissue. Other methodology is keratolimbal allograft and LSCT. Corneal transplantation can be done in extensive stromal scarring after chemical injury, and if keratoprosthesis can be done in case of most for restoring vision in patients who have failed previous corneal procedures. Boston type 2 keratoprosthesis is usually reserved for patients with bilateral corneal blindness in setting of severe dryness and keratinization and severe chemical or physical injury with lots of leads. So these are the summary of management in chronic phase. Thank you. I have to rush. So, like
Thank you, Abhishek. Due to shortage of time, we will take the questions at the end of the sessions, as we are supposed to start our inauguration by 1 p.m. May I now request Dr. Vijay Kumar Sharma to speak on management of complicated pediatric cataract. And may I request the next speakers to please sit in the front row so that we can have the next talk as soon as possible.
Very good morning to all of you. Very thankful to Bihar Ophthalmological Society to giving me the opportunity to present my case. Management of complicated pediatric cataract. As we know, the complicated pediatric cataract is one that is associated with the other ocular anomalies like systemic disease, trauma, infection, or any intraocular inflammation. So management are more challenging than isolated congenital or developmental cataract. So these are the etiology, ocular causes, and the systemic association. So ocular like persistent fetal vasculature, microphthalmia, anterior posterior segment anomalies, glaucoma, uveitis, trauma, and systemic association, torch, infection, metabolic disorder like galactosemia, genetic disorder, genetic syndrome like Marfan, homocystinuria, or juvenile idiopathic arthritis. So we have to do the pre-operative evaluation before proceeding. So we need to take the detailed history, visual function assessment, and the systemic workup. The pediatrician and genetic counseling should be done, and the ocular imaging, biometry, and the corneal diameter. Nowadays we are taking the lens diameter also. So surgical management is different from the conventional pediatric cataract. So aim of early intervention is required, ideally less than 6 weeks for the unilateral and less than 8 weeks for bilateral cases. So use of microsurgical technique under general anesthesia with high magnification, and the primary posterior capsulotomy with anterior vitrectomy is recommendation for age less than 6 to 8 years. And the surgical technique is based on the complexity. So whenever we deal with the subluxated pediatric cataract, so we have to look for the extent of subluxation. If suppose the subluxation is less than 3 clock hours and the 3 to 6 o'clock hour and more than 6 o'clock hour, the management is different for the different subluxation. So here I showing the management of subluxated cataract. So in this case, we can see the almost 6 o'clock subluxation is there. So localized conjunctival peritomy is formed, and flap is made there. So after the triangular flap, the flap is made for the fixate the single eyelid unit ring. So here in this case we need not to put the air, we have to stand with the visco. So first put a high molecular viscoelastic so that dye should not go to the posterior vitreous, so otherwise it will stain your vitreous and the visibility will be very poor. The continuous curvilinear capsular axis is difficult in this kind of cases, but anyhow it happened in this case. So after the continuous curvilinear capsular axis, I use the iris hook. In pediatric cases I usually don't use the capsular hook because in these cases the capsule are very elastic, so there is less risk of tearing of the capsule. So one can use the iris hook also. If one have the capsule hook, then it will be better. But iris hook is smaller and it is microsurgical, so better to use the iris hook. So after that, I pass a 9-0 polypropylene suture underneath of the scleral flap, and the single eyelid Sioni ring is suture, and it is implanted into the bag. So one need not to put the simple CTR, always put a single eyelid or double eyelid Sioni ring. And it should be fixated to the underlying sclera. And the residual cortex, someone can use the cortical remover before putting the CTR, but I prefer to remove the cortex after the putting CTR. So we can see at the end of the surgery, so well center capsular bag, and as the age of the kids in this patient, in this case was around 6 years, so we didn't go for the primary posterior capsulotomy. Patient was cooperative for YAG laser capsulotomy. So another case which showed the pre-existing posterior capsular dehiscence, this also faces a unique surgical challenges. It may be congenital or acquired. So here we can see this is a case of pre-existing posterior capsular dehiscence. So one can see the wild drop reflex in the left eye. So we have to do the UA for the both eye, operating for the right eye, but we have done the UA both eye. We can see the wild drop reflex in the opposite eye. In this case, white reflex is there, but irregular white reflex. So this is also indicating there might be a posterior capsular dehiscence. So in these kind of cases, after the capsular axis, one should not do the vigorous hydrodissection. Just minimal hydrodissection or no hydrodissection. Just expose the nucleus in the anterior chamber. So the minimal hydrodissection was done. And I try to expel the whole of the nucleus in the anterior chamber. We can see the pre-existing posterior capsular dehiscence there. So viscoelastic is injected to prevent the vitreous prolapse, and the vitrectomy is performed. 3-piece IOL is the IOL of choice, and it is implanted into the bag, not into the sulcus. It is implanted into the bag, as the periphery is very good. So similarly, pediatric uveitic cataract, in this kind of cases you need to control the inflammation, and always do the peripheral iridectomy in this kind of cases. So we can see the BSK changes along with the posterior synecdoche. So this is a case of 3-year-old child. So most likely suffering from the juvenile idiopathic arthritis. So we can see the classical BSK change is there, and the posterior synecdoche is there. After the posterior synecdoche, the continuous curvilinear capsular axis is performed, and the primary posterior capsulotomy is also done. We can see the well center primary posterior capsulotomy, and the single piece IOL is implanted into the bag, and after that anterior vitrectomy is done. So control of outcome mainly depends upon the control of inflammation, amblyopia management, and the management of associated anomalies, and the parental compliance is very important. So on conclusion, early diagnosis and intervention is very important. Tailored surgical technique and the multidisciplinary coordination and long-term follow-up and the rehabilitation is very important. Thank you.
Very well presented, Dr. Vijay. Doing a complicated adult surgery itself is a nightmare, so you have very well presented the management of complicated pediatric cataract. May I now request Dr. Rusmika Singla to speak on tunnel infections, the nightmare. The certificates for the presentations are kept outside near the registration counter. May I request all the presenters to collect it from the registration counter. Thank you.
स्पीकर्स के लिए मेरा अनुरोध है जस्ट कि इतना फास्ट भी मत दिखाओ कि हमको दिखाई ही नहीं दे या सुनाई भी ना दे. समझ कहीं ऐसा तो नहीं लगता कि हम सीख जाएंगे. थोड़ा सा ऐसा होना चाहिए कि ऑडियंस को थोड़ा सा कंप्रहेंशन का टाइम मिलना चाहिए कि आप कर क्या रहे हैं, बस और कोई बात नहीं था. इसीलिए तो बोल रहे हैं कि ये उनके लिए भी है जो ऑर्गेनाइजर है, क्योंकि वैसा प्रेजेंटेशन जिसमें हम कुछ भी टेक होम मैसेज ना ले जा सकें तो बेकार है वो.
रुस्मिका को भी 6 मिनट है, 1 मिनट हम लोग खा गए, अब आपको 5 मिनट रहा.
सर मैं नहीं मानूंगी 1 मिनट. First of all, thank you to the organizing committee for making me a part of this beautiful conference. So I'll be talking on tunnel infections, a nightmare. So tunnel infections are infections of clear corneal tunnel or sutureless scleral tunnel after cataract surgery. They are devastating in nature. Gram-positive cocci are the most common organisms. So I'll be presenting a case, a 42-year-old male who came to me after 5 days of surgery done elsewhere with a vision of count finger 1 meter. He had excessive pain, redness, watering, and loss of vision. There was circumcorneal congestion, corneal endothelial deposits, superiorly localized infiltrate around the phaco tunnel. Hypervine was of height around 3 mm, and pupil was medically dilated. So looking at this, we have actually three differential diagnoses. One is scleral inflammation, which is quite demarcated, as you can see in the pics, and TAS, which is one of the common reasons, but in this we don't have corneal infiltrate, and we have anterior segment inflammation with limbus to limbus corneal edema. Another is post-op sterile corneal infiltrates, which is a case study given by of 26 eyes at an institute. It had multiple discrete lesions at the main port, but the main difference is that the patient will not have so much of symptoms, and it will resolve in a month's time. So coming to back to my case, in such cases we should do a microbiological workup, which is must, a B scan, AC tap, confocal in fungal elements if you suspect, and an ASOCT to see the depth and extent of infiltrate. So I did a B scan. The vitreous was quite clear. Took a scrapings from the edges and base of the ulcer. Then on microbiological analysis, it showed gram-positive cocci, and further isolated, which gave us Staph aureus. So started on cephalosporins, which is first drug of choice in gram-positive, fortified CephA 1 hourly, Ciplox eye drops 1 hourly. I sent the patient as the patient was high profile at LVPI Hyderabad, where vitreous biopsy was also taken. Similar report was seen with gram-positive bacilli 2 and a trace of gram-negative bacilli. They did a TABCL on the thinned out area, and vision improved to 636. Patient came back to me after coming from LVPI. After 10 days of the treatment, he was in pain, and the vision again decreased to count finger 1 meter. TABCL was in place. There was no hyperpain, no endoexudates, but a lot of conjunctival congestion. So this brought to me a conclusion of increased inflammation than infection. I started the patient on prednisolone 4 times a day. In a week's time, patient improved, and vision improved to 618. So benefits of steroids in infections too. It increases patient compliance, decreases incidence of stromal melt, neovascularization, and subsequent scarring. So the steroids act on metalloproteinases, which are pro-inflammatory cytokines, which decrease corneal melt, corneal scarring, and hence loss of vision. But the caution to use steroids is grave. You should never use them in gram-negative bacilli, nocardia, for which again our microbiological workup is very essential, and you should have a keen eye as a physician that the infection should have settled down before starting steroids. So you can go through SCUT trials, and SCUT2 trial is also released, and there are many other nice studies which compare steroids and CXL in bacterial keratitis. So most commonly reported organisms in such post-op tunnel infections are gram-positive bacteria, as I told before, Staph aureus, and then gram-negative bacteria are also seen. Fungi are seen in places like India with hot and humid climate. This is a case of nocardia. This is a picture taken from online resource. So these show granular deposits, snowball opacities. These are very rare to be seen. So the best treatment is prophylaxis in operative cases. Using of povidone iodine has been from ages, and it is still the most important thing. Intracameral antibiotics, there are many reports on this, and they are working. Ocular surface preparation is very important to see blepharitis, the lid condition, hygiene of the patient, because most of the organisms are the normal commensals of the eye. And wound management, when you make your phacotunnel or the corneal or the scleral tunnel, the lips should oppose each other very nicely. So takeaway messages: tunnel infections are devastating, need urgent and aggressive treatment, prompt medical therapy and surgical debridement if needed. Best protection is sepsis and prophylaxis. Thank you. Yes, so this was.
उन दिनों जब केराटोम स्टरलाइज नहीं आता था कई बार, तो वो बेचता था और आपको स्टरलाइज करना रहता था, तो मेरा स्टाफ जो है वो उसका फोम के साथ ही साइड एक्स में डाला था, और मुझे पता नहीं था, और सारा केस को यही प्रॉब्लम हुआ, और फिर ऊपर वाला मालिक था मेरा, वो लोग तो बेचारा
So nice to share, sir.
लेकिन मेरा कहना है कि most of the time I think the instrument which you are using for making tunnels, that may be the cause.
That is the
इसलिए
main
मेरा
most
था
of
कि हर बार नया या तो ब्लेड करो, इंश्योर कर लो टेबल पर लेने के पहले ही कि वो पैक फटा हुआ तो नहीं है, वो वहाँ पर लफड़ा होता है.
Yes, this is important. Thank you, sir.
Thank you, Rusmika.
Thank you.
One of the largest series of tunnel infection which came from one of the hospitals in Madurai, not the Arvind Eye Hospital, and they found out it was the contaminated paracaine, contaminated anesthesia drops. So sometimes drops also can cause tunnel infection.
Yeah. Rushmika, you finished in time. You deserve.
May I request Dr. Ranjana Kumar to please speak on tackling astigmatism in cataract surgery.
Good afternoon, everyone, and I would like to thank our CAC, Dr. Gyan Bhaskar, for giving me this opportunity to speak. Topic simplified. Thomas Young discovered astigmatism in 18th century, but even in 2025, when you're putting your baby steps on the phaco pedal, astigmatism falls on your blind spot. The only thing that you are bothered about is taking the nucleus out and putting the lens in the bag. As you grow in, as your learning curve improves and you are adept at your job, then you realize that, and when you start titrating your results, then you discover that the best corrected visual acuity, that means the uncorrected visual acuity that you wanted post-op, the patient presents with 618 partial or 624 partial because you just forgot about the astigmatism. So this is just an overview about the astigmatism management in your post-cataract patients. There are now studies onto the prevalence in Indian population, which is approximately 40% in patients undergoing cataract surgery with more than one diopter. This is an approximate value. And surprisingly, 40% is the number of surgeons who are actually actively treating astigmatism in their practice using different procedures, corneal or IOL-based procedures, and not depending on spectacles alone. The magnitude is such, more than one diopter, as I said, 45%, and only 8% people or 8 to 10% have more than 2 diopters of astigmatism if you're going to operate on the patient. And of course, all of us are aware of the physiology that it is with the rule when you're young and it goes against the rule as you age. The impact is decreased visual acuity and visual disturbances. And for a post-op patient to explain, we need to understand that no matter what they spend, they always want a spectacle-free life, and it is very difficult to tell them that, well, you need spectacles to have a clarity of vision post-op. And when you correct it with glasses, the satisfaction is definitely not as much. The post-operative astigmatism less than 0.5 diopters is what we want, what we aim for, and this is what is required to give spectacle independence. And cataract surgery, now you need to bring that astigmatism into your foveal fixation, and because there are so many techniques available and it has advanced so much that you can deal with it head on. Now, for correcting astigmatism, the diagnosis is important. You need a biometry and topography if you are on a premium, and if you are one who's well established into your craft. But having just an ARK and an immersion biometry should not deter you from using such practices, astigmatism correction methods in your practice. First and foremost, there are 4 ways to deal with it. You need to put a clear corneal incision on the steep meridian. First of all, the simplest method, you can add an opposing clear corneal incision, because that is what adds to your initial incision. You can have peripheral corneal relaxing incisions or LRIs that we said, or finally, you can opt for a toric intraocular lens implantation. The simplest approach is, of course, put your incision onto the steeper axis. SIA is not always harmful, but it always helps in reducing. It can also help in reducing and eliminating pre-existing corneal astigmatism. And as we know, it is proportional to the incision size, and the severity depends on the length, width, and location of the incision. If you're using a 1.8, 2.2, or 2.4, almost you're not inducing any astigmatism to the patient, as we all know. If you go from 2.8 to 3 millimeters, then you are making a difference. The placement of incision helps at the steeper axis, helps you correct if the astigmatism is less than 1 diopter. A larger incision causes more flattening. If it's more central, then it causes more flattening. If it's more deeper, then it causes more flattening. Now, if those patients for whom you have an astigmatism of 1 to 1.5 D and you want to neutralize it, you can go and use an opposite clear corneal incision. You do a phaco through the main incision, and just diametrically opposite, you make a penetrating incision of the same size. This enhances the flattening effect of the main incision. I'll just run one video, not my own. Thanks to the World Wide Web for providing me with this. You need to mark the site where you need to make an incision. This is the phaco tunnel that he enlarged, and then just diametrically opposite, you make an additional incision. And the first case, this one, marker has been used to mark the axis so that it's easier for the surgeon to put the incision. Why am I not going to the next slide? So these single or paired limbal relaxing incisions, these PCRIs provide, this is the next step that you can do, that is peripheral corneal relaxing incision. They can provide correction of 1 to 3 diopters of astigmatism. And if effectively corrects the lower level of astigmatism, but if the astigmatism is higher, then you need to think twice before using it as a treatment modality. There is an online calculator. It's available to all. You can log into it right now. It is an lricalculator.com, and it uses a nomogram. It gives you the incision size. It's incision as per your advantage, whether you want to put it at 90 degrees or you would put a temporal incision. It will give you the axis where you need to mark the arc length of the incision, 6 millimeters or 8 millimeters, number of incisions, axis of placement. Everything is given just like baby steps. This is the kind of the format that you see when you use the LRI calculator. You need to put in the data, mainly your steep K, flat K, as well as your pachymetry if you are using the one of the nomograms. The marking of the LRI is generally 0.5 to 1 millimeter inside. Guarded blade is something that you need specifically because you don't need to perforate, and you need a nomogram to use the nomogram. I'll just run this video because this is not something that we do. You just mark the axis, and then you put a deep cut, and you're not supposed to perforate the cornea. You need confirmed keratometric readings. You need to know that it's correct, and you have to compare it with the refraction. There can be complications. You can perforate. There can be decreased corneal sensation as you cut the nerves. You can induce irregular astigmatism, and you need to understand all that before you proceed onto it. This is the nomogram, where the number of incisions that you need. The advancement, well, if you have a femtosecond laser, then you are forced to practice LRIs, and you can use it, and you can titrate your results accordingly. It helps reduce the potential for human error, and it improves your outcome definitely. So that is one more advantage that you have in your armamentarium. As an add-on, you can use it with multifocals and all if you think that there is a residual astigmatism that is remaining. Toric IOLs remain the gold standard for correcting pre-existing astigmatism, and then it can help you correct up to 6 diopters of correction can be done with that. You need your data. You need to know your SIA, your posterior corneal astigmatism. We need another talk to explain that. And then you need to use your toric calculators, which is either inbuilt into your machine that you have, or you can give it to the person who's supplying it. You have different companies have very good quality, good result orienting lenses. If you aim for perfection, you just have to align them well. The preoperative marking, now this has become almost obsolete. You do a slit lamp marking available to everyone, and it's a cheaper version. And for the more evolved practitioners, you have the inbuilt Varion markers. They are the image guided systems. The toric IOL comes with the definite markings which you need to orient. I'll just skip it. You can have a misalignment if there is a miscalculation. There are changes, you have induced changes in the cornea that are not accounted for. And of course, you forgot about the posterior corneal astigmatism. And IOL stability is important because it depends on the material, the design, and the incomplete removal of viscoelastics during surgery is going to be a pain. And very early rotation can be due to lack of adhesion if you have left behind the OVD. And important, there are studies which say that patients with the rule and oblique astigmatism are more prone to rotation. Rotation occurs early in the early post-op period within the first 3 days post-operatively, and maximally occurring between the first and 1 hour to 1 day after surgery. And it may decrease when the anterior and posterior capsule fuses, so that is after 2 weeks, and minimal is observed after 1 month. When you want to correct the orientation, if you've done it wrong and if it is rotated, it is within 1 to 3 weeks before it fuses, and it's easier to move the aisle around. Biometry errors, large axial length post-op ACDs can cause you an error.
Ranjana, twice time passed.
Yeah.
Please.
And the verdict is that please use toric IOLs because you can use it even beyond 0.75 diopters of astigmatism, and that will be the answer to all your solutions. Thank you. And it is the most rewarding and the most forgiving of surgeries. Don't think about it, just do it. Thank you.
Very well comprehensively covered, Ranjana ma'am.
Just one small announcement, please. After sitting here, I realized it's quite disturbing for the scientific deliberations we have, so we have closed this gate. We will be using the back gate, so please use that one. Thank you.
May I now request Dr. Sunil Singh sir to deliver his talk on outcome of customized toric intraocular lens for cataract associated with high astigmatism and case studies.
Thank the organizer and PR of Human Society for giving me this opportunity. The topic is outcome of customized toric intraocular lens for cataract associated with high astigmatism or case series. No financial interest. Astigmatism cause decrease in visual acuity and decrease in contrast sensitivity. Prevalence is 10 to 13% of refractive errors. In spherical cornea, the curvature is same in all meridians. When astigmatism is present, there are two principal meridians. Regular astigmatism can be of 3 types: with the rule, against the rule, and oblique. You can see with the rule, the first one, the steepest curve is this, between this 120 degree and 60 degree. And the against the rule is again between the 30 degree and 150 degree. And the oblique one is between these two. Whenever the two principal meridians are not symmetric and do not lie 90 degrees apart, the astigmatism is considered irregular. Astigmatism can be corneal, lenticular, or posterior pole. Method of correcting is toric IOLs, limbal relaxing incision, in which Ranjana took so much time, and then it's a clear corneal incision, and 2-stage procedure with excimer laser ablation. First, you do the monofocal lens, and then you do with excimer laser. But then the best one, the Ranjana also said, is the gold standard is toric IOL. Predictable, procedure of choice to correct corneal astigmatism of 1 diopter or more. Ideal patient is with a regular astigmatism, but good outcomes in case of stable, mild, central, irregular astigmatism and pellucid marginal degeneration, stable, moderate stable keratoconus, not fit, zonular instability, posterior capsular dehiscence, irregular corneal astigmatism, poor pupillary dilatation, and prior vitreoretinal procedures. Workup should be very important. Complete ocular examination, pre-operative patient counseling, astigmatism measurements, IOL power calculation, intraocular lens selection, marking techniques, and residual astigmatism should also be measured. Stop wearing soft contact lenses 2 weeks prior and rigid gas permeable lenses 3 weeks prior topography surgery. It is essential to evaluate the posterior corneal astigmatism while calculating total corneal astigmatism. IOL power calculation, you give the thing, and every lenses has some different, and the company people give you the calculation, taking into account everything. Marking methods, it can be image guided like Callisto, and intraoperative aberrometry is of a great help. And the post-operative outcomes depend on the marking method, IOL material and design, intraoperative factors such as capsular access, sealing of corneal incisions, and surgeon experience. the applications of toric IOLs are expanding to include cases with high astigmatism, irregular astigmatism, corneal ectatic disorders, and post-PK cases. I am presenting a case series of 5 patients. I'll present 4 because of paucity of time. One is with irregular astigmatism. Regular toric IOLs would correct astigmatism only up to 6 diopters in the IOL plane. More than that, it is customized. You have to give order to the company, and company will customize it and then give it back to you. Case 1, a 65-year-old male presented with vision in the left eye. He had there was no history of contact lens usage. Slit lamp examination revealed an inferior band of corneal thinning. This you can see. The things to note is against the rule astigmatism of 12.1 diopters, 12.1, with the characteristic crab claw configuration which suggests PMCD, pellucid marginal corneal degeneration. You can see that. Both eye with PMCD with significant cortical cataract. One, the toric IOL of 16.5 diopter is implanted, and another toric of 20 diopter was implanted. This is the customized lens. You don't have to rotate. They give you the plate haptic. You sit temporarily, and we implant straight away. It should be there only. Result is very good. You can see the BCVA was 6/9. Left eye also, right eye also, and there was no distortion of image. Post-op you can see, case 2 is almost similar. Both eye is, this is second case. The toric IOL is, one is 13 diopter and another is 6.5. This is same thing, and the same 6/6. This came to 6/6 in the right eye and 6/9 in the left eye. Case 3 is had a history of blunt trauma 6 months back. So there was subluxated lens. So you can again see that he against the rule astigmatism of 4.8 diopters calculated. But traumatic subluxated lens was there, and left eye was clear lens. This is 6/6 again, but you have to do what you had to CTR, and its CTS assisted was there. That was the difference, but result was equally good. Toric IOL is not advisable in highly irregular astigmatism. We did it, and we did not have good result. I can show you the result. Patient was very unhappy. The thing was done. It was 6/60. So it is not to be done in irregular astigmatism. The over enthusiasm lead to it, but the result is poor. Patient is unhappy. So I can say that toric IOL is there, and I thank you all for a patient hearing.
Thank you so much, Sunil sir. Very well presented. May I now request Dr. Santosh to present on changing trends in secondary IOL. Dr. Santosh, please.
Abhishek ka hai? Abhishek, we need to just, we can do it after this talk, but we just need to break for inauguration, and then we'll continue the session.
Okay, sir.
Thanks. Please go ahead. एक्चुअली डीआईजी साहब को जाना है, इसीलिए बैठ जाइए, तब 2 मिनट बैठ जाइए, ताकि हम लोग को सेटअप करने में भी टाइम लगे। हमको रवि भैया बोले आ गए।
सर 1:30 में आएंगे, 1:30 में।
तब संतोष बोल लो, संतोष आ जाओ। सुधीर भैया आ जाइए।
Very good afternoon, all the dignitaries on and off the dais, and thanks to the boss CSC and all the boss office bearers for inviting me and having me here. So my topic for today is secondary IOL, and probably it's taking some time. Okay, so the topic for today is secondary IOL. So as you all know, the management of aphakia, spectacle correction, then contact lens, refractive corneal procedures, and then comes the secondary IOL. So for aphakia, these three IOLs, iris fixated, AC IOL and SF IOL. Today we'll be mostly discussing iris fixated IOL and SF IOL and the different techniques of it. So retropupillary iris claw has clearly, outclassed anterior chamber, which is like anteriorly fixated, because of the simple reason that it is away from cornea and it is more physiological in position, and it causes less endothelial damage, and PI is not always required. So I will be just presenting few surgeries here that just to show that iris claw can be done in same sitting using the same SICS tunnel that is used for either the primary case or taking out the the complicated IOL. Just you have to take the haptic beneath the iris. You have to indent upward and then just tuck inside between the two haptics. The second one, the IOL drop, it was there, and after that meticulous vitrectomy need to be done, and this is considered to be having shorter learning curve, and that is why it is very much practiced in high volume center, and it is advisable to go in the same sitting also, like in the primary setting. So these were two IOLs, and the contraindications for iris claw is obviously aniridia, ischemic vascular occlusion with rubiosis, iritis, uveitis, and then comes the much talked about scleral fixated IOL. So for that we are doing a couple of modifications. The first one, this one is the partially resorbed lens. So after taking out this cataractus and partially resorbed lens, I am just going to show the X-knit technique. You have to mark this exactly opposite 180 degree. And then after doing the peritomy 1.5 millimeter behind the limbus, you just come introduce 26 gauge needle. Just come and introduce the haptic inside the lumen. Take it out, and just to just to avoid the slippage, there is silicone sleeve that you can see here. While doing the maneuvering, you can just the sleeve actually protects the slippage. As all the maneuvers are being done here outside the anterior segment, anterior chamber, that is why it can be done even in slightly hazy cornea also. As you can see here, this was a little bit of hazy cornea inferiorly. After that, a scleral groove is being created here, and this groove you have to see, and you have to make it in alignment with the the direction of the haptic, so that it should not be twisted, otherwise it just may come out very easily. Then by max grip forceps, just get the tip of the haptic and introduce that inside the groove. So this was one technique that is being practiced widely. The other ones are also that we have done a little bit of modifications, that we currently we are doing some thermocautery. So in the second case, as you can see here, the first one I have already exteriorized. Thermocautery is being done here just to avoid slippage. So instead of the sleeve, silicone sleeve, here I am just doing thermocautery, and this technique I am going to make it just subconjunctival, the knot, but it is not very highly recommended. It is only done for uncooperative patients and patients with the deep-seated eye. The third case, here also thermocautery. So thermocautery will help you very much for making this knot, and knot either you can leave it subconjunctival, which is not very highly advisable, but you can also put it in the scleral groove, which I am going to make it here. And And the amount of thermocautery, that also you have to decide it properly so that the stump left should be good enough for being introduced into the groove. So here, and the knot, definitely the stability is more here in the case of not being introduced into groove. So that's all, these three techniques of SFIL. So clearly sutureless SFIL is having better anatomical location, proper centration and haptic pocketing is must. And pupil deformity, which is a problem mostly with iris claw, is not here a problem. And the take home message is retropupillary iris claw. Mid dilated pupil is best suited. Less time or short learning curve makes it quite doable in primary setting, and it may be preferred in large volume centers. While SFIL centration and avoiding tilt is the most important thing. The long learning curve is there, but it may be done in relatively opaque media also, and it is preferred for uveitis patients or aniridia or iris atrophy. Thank you very much for your kind attention and patient listening.
Santosh, very nice presentation. Just one thing, we were using Kelman multiplex earlier. What is the space in this area of that Kelman multiplex ACIOL?
Sorry, sir, you were talking about iris claw. Right?
No, Kelman multiplex.
ACIOL. So, sir, ACIOL actually it was widely being practiced previously, but as you are a little bit directly engaging the angle of the anterior chamber, so first chances of secondary glaucoma is more, and then also endothelial cell loss is also more there. So people, I think, have now shifted to
People are not using nowadays.
Not using, sir, because of the secondary glaucoma.
So
and other things.
retina persons have shifted to SFIL.
SFIL
And
mostly.
What is there for anterior segment surgeons?
That is why, sir, I saw actually this one.
Iris
because
claw.
Iris claw is the better one because it takes very less time and also the learning curve is short.
Okay,
So
thank you.
otherwise you can do everything. Thank you, sir.
Thank you, Santosh. May I now request Dr. Manoj Kumar Singh to present on effect of tacrolimus in refractive VKC as monotherapy and combined with olopatadine. Dr. Manoj, please.
Good afternoon to everybody. Thanks to CSC for giving me a chance to talk in this session. My topic is tacrolimus and the combined use of tacrolimus with olopatadine in refractory vernal keratoconjunctivitis, a comparative prospective study. Introduction. Vernal keratoconjunctivitis is a sight-threatening chronic inflammatory eye disease frequently seen in children and young adults. It usually starts after 5 years of age and persists for 2 to 10 years, resolving by puberty. Though it may start earlier and continue well into adulthood. Male to female ratio in this disease is approximately 2:1. The disease is seen mainly in tropical climates such as in countries surrounding the Indian subcontinent, the Middle East, the Mediterranean, in West African nation and in Japan. The prevalence of VKC in tropical region may be up to 5%. Comparative evaluation of tacrolimus 0.03% ointment versus olopatadine 0.2% eye drops in treatment of vernal keratoconjunctivitis. The patient may experience different phases of because of fluctuation of inflammatory process of the disease, and these may result in decreased quality of life and permanent corneal injury. Patients are visually handicapped because of the severe itching along with lacrimation and mucoid discharge, photophobia, burning and heaviness of eyelids due to the involvement of tarsal conjunctiva. Conjunctival signs include hyperemia, diffuse fine papillary hypertrophy, micropapillae, giant cobblestone tarsal papillae in some variant, and limbar papillae with hornal transverse dots. Purpose is determine efficacy of topical 0.03% tacrolimus as a single versus its combination with 0.1% olopatadine in VKC. Currently, olopatadine is one of the most commonly prescribed antihistamines for the allergic conjunctivitis. Tacrolimus, on the other hand, is an immunosuppressive drug which is now increasingly being used as a steroid-sparing treatment option in VKC. Methodology: 50% of VKC selected and divided in two groups. Group 1, 0.03% tacrolimus ointment applied twice a day. Group 2, 0.1% olapatadine ophthalmic solution was applied twice a day with 0.03% tacrolimus ointment. Patient has examined on slit lamp and clinical features were graded on the scale 0-3 before the initiating therapy on the day 7, 30 or 90. This is the graph show the effect of tacrolimus and its olapatadine. Result: there is significant reduction in sign and symptom of both the group on day 7, 30 and 90s. Multiple prospective studies have been conducted comparing the use of topical tacrolimus alone versus with combined use of tacrolimus with olapatadine for the treatment of vernal keratoconjunctivitis. Current research indicates that both tacrolimus alone and combined use of tacrolimus with olapatadine are effective in managing the vernal keratoconjunctivitis. Tacrolimus may be particularly useful in case unresponsive to conventional treatment and may offer a steroid-sparing alternatives. More research is needed to determine the optimal dose and long-term effect of this treatment, as well as for the further explore the efficacy of combination therapy versus monotherapy. In this study, tacrolimus and group B tacrolimus with olapatadine, severity of signs and symptoms were found to reduce on 90 days in both the groups. Punctal epithelial keratitis by 96%, limbal gelatious infiltrate by 89% in group A and 95.5 and 89% respectively. In group B, prompt and considerable improvement in symptom of refractory VKC was found in both A and B group. In present study found that group A and group B have similar efficacy in reducing the sign and symptom of VKC with minimum discomfort. Itching has been seen be mostly relieved in all patients after 7 days of treatment. Majority of symptom has been alleviated. There is a marked improvement in objective sign with time, such as decreased hyperemia within 7 days, improved conjunctival papillary hypertrophy and giant papillary in 1 month, and improved limbal hypertrophy and corneal sign in month. Conclusion: the single use of tacrolimus and combined use of tacrolimus with olapatadine have similar efficacy in reducing clinical symptom and sign in case of vernal keratoconjunctivitis, which are effective to the conventional therapy. This is the reference, and thank you.
Thank you, Dr. Manoj. So you have spoke on relatively very common topic these days.
I will like to invite some comment from Dr. Divakant. As he said, tacrolimus to be used twice a day. Usually we practice tacrolimus at bedtime because many times using in daytime that causes photophobia. What is your say?
Yes, sir, very rightly pointed out. It does cause, and patients do complain that. So in my practice, I also recommend nighttime dosing of these. Yes.
Okay, thank you, sir.
May I now request Dr. Ashish to present on cross-linking the keratoconus? Is that enough? What's next? Dr. Ashish, please.
Thank you. A very good afternoon to all of you. I'm very thankful to Dr. Gyan sir and especially Dr. Ravi sir and Amitabh sir for giving me this opportunity, and glad to see all colleagues and teachers and Diva, and was nice meeting Dr. Praveen here. My topic is cross-linking the keratoconus. Is that enough? What next? Since we are seeing increase in the numbers of keratoconus, the numbers of cross-linking has also increased because of the basic fact that it's a proven technique which has shown over a period of last 10 years. It's quite efficacious and helps in de-accelerating the or sometimes even stopping the progression of keratoconus. Keratoconus, as we all know, it's a bilateral asymmetrical ectatic disease of the cornea, and one of the most common factor which is associated with keratoconus is the allergy, and it's quite common in Southeast Asian country, most common in the Middle East, and we are also seeing the numbers of cases of keratoconus increasing day by day. Our diagnosis is sometimes tricky, but if we are suspicious, we can all diagnose keratoconus just by seeing patient or doing a scissors reflex or doing a refraction. So anything which is where K reading is more than 45, 46, we should be suspicious. If corneal thickness less than 470 microns, we should think of keratoconus, and the definitive diagnosis is because of the topography or tomography we have. And nowadays they are so advanced that they can even indicate, even if you don't know how to read topography, there is machines now where you can actually, they will show you the grades of keratoconus. It's a grade 1, grade 2, grade 3, grade 4, and also they will tell you whether the patient has undergone surgery or not, refractive surgery. So topography has become much intelligent than it was before. This is a typical pentacam image of keratoconus. So basically there are two aspects of the disease. One is halting the disease progression, which is done through cross-linking, and the other is restoring the best corrected vision in these patients. Some of the parameters for progression is mentioned here. None of them are validated, but they are mostly used in all the studies which was done on cross-linking. So if there is a increase in keratometry, for steep keratometry by 1 diopter, or there is an increase in flat K by 1 diopter, or if there is a thinning by around, there's a decrease of around 2% from the baseline. Mostly these are the things which you should keep in mind before evaluating a patient for a cross-linking. We naturally there is not much we can do to control keratoconus except rubbing. So we always tell our patients not to rub, and there are few anecdotal reports of where it has been mentioned that sleeping with a face down prone position has been shown to increase the progression of keratoconus. And the therapeutic way is by using use of cross-linking, we can halt the progression. So there are different protocols for cross-linking. One of the most common is accelerated cross-linking, and there are some studies which has actually showed the number of keratoplasty has decreased over a period of time since the invention of cross-linking. So some of the objectives which we achieve with the cross-linking is that we actually prevent the worsening of vision in these cases, and also it helps us to fit contact lenses or plan further surgeries in these patients. This is one of my patient differential map, which you actually show. There's a very obvious flattening was done with cross-linking after 2 years. Another patient where you can see an obvious flattening of keratoconus even just after 1 year. So we can, after cross-linking is done, we can plan glasses or a RGP or a scleral lens or a ICL, or sometimes cataract surgery where you can plan toric lenses or a laser vision correction in these patients. We have to be very careful while doing cross-linking. It's not just any other day procedure. There is a risk of infection, there is a risk of haze, and there is a risk of pertinent risk of continuous flattening in these patients. RGP, we all are aware, it's a relatively smaller lenses compared to the scleral lenses. Scleral lenses have become more popular nowadays, and the speciality of these lenses is they can even fit in keratometry readings of even around 80 diopters. So any advanced keratoconus can be fitted with scleral lenses nowadays. This is a typical photograph of a scleral lens, and this is one of the patient who has a central apical scar, but still achieved a very good vision with scleral lens, around 6/9 vision for these patients. Now scleral lenses also advanced, and it is coming with now wavefront optics, where you can actually even take care of the higher order aberrations, apart from myopia, hyperopia, and astigmatism. And ICRS is there. The number of users of ICRS has decreased after the Keynes, which was actually founded by Dr. Susan Jacob, And it's quite a good procedure. The disadvantage is that we don't have femto, so we could not practice this. But these are nothing but the allogenic segment where we actually implant in the cornea on this steeper side to make the cornea flat, based on the principle of short arc technique. And some of these keratoconus you can also use ICL, where you have achieved a stable keratoconus, or you think it is not progressing, and obviously there should be it should fulfill the criteria of ICL. This was one patient where I planned ICL post keratoconus. This patient had a good amount of astigmatism, where I didn't do toric ICL in this patient because I thought it could progress. I'm just about to finish. So you can also combine cross-linking with some of laser vision correction. One of the protocol which we follow is Athens protocol, where you can actually combine topo-guided PRK with CXL. The procedure has shown good results, but you should be very careful with your selection criteria. And finally, you can do keratoplasty in these patients if it still progresses beyond a certain extent, and DALK is the preferable way of handling these patients. So in conclusion, careful case selection for cross-linking is very important, is one of the first step of a very long journey of visual rehabilitation in these patients. And scleral lenses are one of the most common useful way of rehabilitating in terms of vision for these patients. And KS and ICL are now being practiced for keratoconus quite often. DALK is reserved for very advanced cases. Thank you.
Thank you, Ashish, for bringing this alarming topic. And if detected early, the keratoconus, we all know that the results are wonderful. May I now request Dr. Nidhi to speak on corneal ulcer demystified for the postgraduates. Dr. Nidhi. If time permits, we will take the next talk of Dr. S.P. Tiwari next, intraocular foreign body removal, different techniques.
Very good morning to all of you. Thank you, Scientific Committee boss, for having me here. So let us see approach towards corneal ulcer, especially from a perspective of postgraduate. I haven't included viral ulcer here because the diagnosis is mostly clinical. So first and foremost, whenever a patient walks into your clinic, you have to assess the severity. How severe is the ulcer? The next thing is you have to identify the organism, apply appropriate antimicrobials, and the surgical timing is the crucial one. So how would we assess the severity? You have to grade the ulcer into mild, moderate and severe based on the size. When it is less than 2 mm, it comes under mild, moderate is 2 to 5 mm, and anything more than 5 mm is severe. Similarly, less depth comes under mild, 20 to 50% is moderate, and more than 50% depth comes under severe. Whenever there is a scleral involvement, it makes the ulcer into severe grade. This is the profile of causative organism in our area, not going into the details. So we have to now find out the organism. So there are many clues from the history, like whenever, as you all know, whenever there is history of trauma with vegetative matter, or there is a history of use of over-the-counter steroid drops, the first thing that comes to your mind is fungal ulcer. Whenever the patient is wearing contact lens, prolonged contact lens where history is there, if the course is acute and fulminant, you think of Pseudomonas, but when the course is chronic, associated with intense pain, you think of acanthamoeba. In post-LASIK patients, according to the literature, the most common organism found is atypical mycobacteria. Now, let us see what are the diagnostic clues from the examination point of view. Whenever you get a case with relatively round circumcised ulcer with surrounding clear cornea, you should think of Staphylococcus ulcer. The serpiginous ulcer points towards pneumococcus, and whenever there is ground glass appearance in the surrounding cornea with relatively acute course with lot of stromal thinning, desmetocele formation, you think of Pseudomonas. Whenever there is a string of pearl appearance or wreath-like pattern, you think of nocardia, and cracked windshield appearance is seen in atypical mycobacteria. Fungal ulcer would be dry looking with feathery margins, and you will be having fixed hypopion. We get we get plaque in case of demotious fungi. Do not confuse it with iris prolapse. In case of acanthamoeba, we get ring infiltrate and there will be intense pain. And in examination, we often ask which is the most common infection in contact lens users. So the answer is Pseudomonas. So when is the staining and culture sensitivity important? So when you are sitting, ideally when you are sitting at a tertiary care center, you should have microbiological examination for all the ulcers. But when you are practicing at a peripheral center where the facilities are not available, you should be knowing when is the time for microbiological profile to be done. Whenever the ulcer is centrally located, involving visual axis, when the infiltrates are multiple, there is history of previous corneal surgeries or atypical findings, you have to have staining and culture sensitivity done. So scraping is done under topical anesthesia with 15 number blade and or Kimura spatula. And the important point is you have to remove the superficial slough, then only you have to send the material for culture sensitivity, okay? So the material should be taken from the base as well as from the margin, and we send for KOH bound gram staining, and for we have got several culture medias. Now you have sent for culture report and you have started your empirical treatment based on your clinical picture and the similar results. If culture report comes out to be supportive, well and good, but even if the culture report is not supporting your treatment, but your ulcer is responding, you have to continue with the same treatment. So summarizing the treatment, in case of mild bacterial ulcers, monotherapy with fluoroquinolones works well, but whenever there is moderate to severe ulcer, you should be prescribing fortified antibiotics in the form of third generation cephalosporins and aminoglycosides. For atypical mycobacteria and nocardia, amikacin works well. For fungus, we have different topical antifungus like natamycin, voriconazole. In case of demotious fungi, we have to remove the plaque. For acanthamoeba, we have PHMB and chlorhexidine. And to manage the intense pain, you should be prescribing higher analgesic in the form of amitriptyline. So surgical timing is very important. Wherever your ulcer is not responding to your optimal medical therapy, or there is impending perforation, or the ulcer has already perforated, you should go for surgical management. Whenever there is a small perforation, you can do it with cyanoacrylate glue along with application of bandage contact lens. And when the perforation is large but present peripherally, we can get away with patch graft. But when the ulceration is central and large involving visual axis, the only option is therapeutic PK. So the take home message is, whenever you get a patient of corneal ulcer, you should be quick in your diagnosis and starting of management. Proper scraping is a must after removing the slough tissue, and surgical timing is very important to have to prevent untoward outcomes. Thank you.
Thank you, Dr. Nidhi, for presenting well within the time. May I now request Dr. Satyaprakash Tiwari to present on intraocular foreign body removal, different techniques.
Thank you, BOS Scientific Committee and organizing team for having me here for this talk. I'm going to discuss about retained intraocular foreign body different situation. I would like to pass a message to all the audience that whenever we see a trauma, the case which might appear a closed globe injury, still we should go for at least an X-ray orbit to look for some hidden retained intraocular foreign body, because many a times we do see that there was a foreign body which was not detected on time, and that led to grave complications later on. Ideally, CT orbit or X-ray is a must apart from USGB scan to look for presence of any intraocular foreign body. Sometimes foreign body is very obviously visible, like in this situation there was a chisel hammer injury and there was a penetrating wound in the cornea and the lens was stuck in the anterior vitreous cavity. That foreign body was stuck in the anterior vitreous cavity. So we decided to do rhexis and then aspirated the lens matter, and we we thought that we will plan foreign body removal after removing the cataract. But in this case, we were fortunate that just by removing that cortical matter of the lens, the foreign body automatically was pushed with a gush of vitreous in the anterior chamber. And here we can see that there was a PC rent posterior capsular defect, and foreign body came out automatically with a gush of vitreous. So we removed that foreign body, and then we did anterior vitrectomy. And since the capsular margin was very well intact, we implanted a single piece intraocular lens in this case and closed the case. So we may be fortunate in many such cases where we don't need to do a lot of maneuvers and go into the posterior segment to remove the foreign body, but the condition may not be similar in many cases, and we have many a times very challenging and tough time to explant this retained intraocular foreign body. This was a case of retained intraocular foreign body around 10 years back. The patient had injury, penetrating eye injury. There was traumatic cataract. Cataract surgery was done. There was a PC rent. Anterior vitrectomy was also done, but X-ray was not done, and the foreign body was missed. After 5 years, siderosis bulbi set in, and that led to vasculitis leading to branch vein occlusion. And then patient came to us with reduced vision, and we saw and we thought that this is retained intraocular foreign body. So this foreign body was removed. In the right hand, with the help of aspiration of the cutter, I am holding the foreign body. With the left hand, we can do a clear corneal entry, and it was a metallic foreign body, but it was 5-year-old and rusted, so it lost magnetic property. And so we removed this foreign body with the help of McPherson's forceps. Foreign body was removed, the area was lasered, IVTA was injected to take care of macular edema secondary to branch vein occlusion, and the case was closed, and this case did well in the end. This is very old case of mine operated. There was a injury followed by some particle jumped out of a grinder machine. That blade of the grinder machine broke off and went inside the eye of that person who was using it, and there was a peripheral large retinal tear, and foreign body migrated through that tear in the subretinal space. It was lying behind the macula, behind the retina. So we did a small retinotomy and removed that foreign body linearly. It was a very large nail, and then we decided to take it out through the sclera, and there was an opening made near one of the working port in the sclera, large enough to take this foreign body, and this foreign body was taken out, and the patient did well after removal of the foreign body. So the patient was very fortunate that all the important visual areas, optic nerve, macula, all were intact in spite of having such a large foreign body inside his eye. So we can see this was a very large foreign body, and it was taken, and it was around 14 millimeter in the length, curvilinear foreign body. So, but since it was a magnetic, it came out very easily. Another foreign body case I would like to say, this is a young boy while playing with the pencil tip went inside the eye. One of his friend just thrown a pencil and it went inside the eye. And these cases are very bad actually. These foreign body are not magnetic, so we cannot use magnet. The edges are very slippery and it is quite large also, so simple forceps are not holding it. I am using a large clawed forceps, and after at least 10-20 efforts, whenever I was holding the foreign body, it was falling inside. After 10-20 efforts, we could finally take it out, and then we closed the wound and we put silicone oil in such case, and such cases also do well. But what I found that glass foreign body and this pencil tip foreign body are very tough to remove as compared to all other foreign bodies. So this was all about some of the cases of foreign body. Thank you all for listening. Thank you. Yes, sir. Pencil tip? Yes, sir. That is exact that HB pencil which kids are using. No, but it is not magnetic, not at all. We have tried. See, if there is a free floating foreign body, even if it is innocuous, we must remove it. If we see some encapsulated localized foreign body, which is not metallic in nature, which cannot harm the eye, and removal is difficult, then we may think of leaving it as it is. But if it is a free floating foreign body, whatever is the nature of the foreign body, we must remove it.
Thank you.
Thank you.
Thank you, Dr. Tiwari. May I now request Professor Dr. Amit Raj to speak on preservation of corneal donor tissue.
First of all, I must congratulate Raviranjan sir, Amitabh sir, Dr. Amresh and whole of the organizing committee for organizing so beautifully. And I also thankful to Gyan Bhaskar sir for being me here. So coming to the topic, as first keratoplasty has been performed in 1905, and then after that there was a very long time after that the ideal media was invented. So why this corneal preservation media is important? One of the important factors is basically at the time of transplantation, you may not have the ideal patient or the ideal, you may not have the logistic. So that is why you need time to plan the surgery. So currently around 70,000 corneal transplant is being done, and we need at least 1,000 corneal transplant. For that you need at least around 2,70,000 donation. So that is why there is role of corneal preservation. So main function to maintain the endothelial viability and integrity, to prevent corneal autolysis during storage, and last the most important is the long-term corneal storage. So Magie-Tot was the first who has given the idea of storing the cornea in hemolyzed blood serum. Later on, moist chamber being used, even nowadays it is being used, but with advent of very good media, mostly moist chamber is obsolete. So there was a lot of work by Berkey, Sachs, Stocker, Summerlin. So main after with advent of MK media in 1974, this corneal preservation is systematized, and then K-Sol, CSM, Dexol, and after that Optisol, Optisol GS, and newer media like chain medium, Urosol. So a ideal preservation media should be comprised of a base media, a buffer, antibiotics, dextran, chondroitin sulfate, and different types of vitamins, and another important thing, the pH indicator. So these are the these are the features of a ideal preservation media. So this preservation media is divided into three types: short term, intermediate, and long term. In short term, moist chamber method and MK media. In intermediate term, K-Sol, Dexol, and Optisol GS, Cornisol, that is the Indian version, and U-Sol. In long term, organ culture, cryopreservation, gamma radiation, and glycerol. Mostly glycerol is used. So coming to the MK media, its most important components are tissue culture medium, 199, 5% dextran, bicarbonate buffer, and penicillin and streptomycin. Basically, gentamicin is the antibiotic. So in this media, tissue can be stored for up to 4 days, but mostly 2 days are basically ideal. These are the intermediate term media, K-Sol and Dexol. And this Optisol GS is very important because the Indian version available is Cornisol, that is equivalent to Optisol GS. So it has again tissue culture medium 199, medial MEM and early solution, and there is gentamicin and streptomycin as antibiotic, and there are other factors, vitamins and other small minerals. There is a role of asteroid also. In some study, it has been found that adding asteroid can give good viability to the storage medium. Coming to the cortisol, this is equivalent to the Optisol GS, and in most of the study, it has been found to be equivalent in different parameters. Coming to organ culture media, again, tissue can be stored at 31 to 37 degrees centigrade, and these are the components. This aerosol again newer medium, it has better characteristic in the terms of endothelium and epithelium, and it is better than the European culture media, and its duration of storage is 28 days. These are the disadvantage. Basically, you need culture report prior to transplantation, and again cornea thickens with the time. There is chances of microbial contamination. Cryopreservation is again very important, but you need basically good quality of refrigerator with 196 degree or even minus 80 degrees centigrade temperature control. Glycerol is very easily available, one can use. So basically again in the COVID era it was very useful because non-availability of the regular donation. So in that cases glycerol can be used, but only problem is the basically endothelium is non-viable, so that is why it is not for the optical keratoplasty. Gamma irradiation is although theoretically very good procedure, but it is very costly. You need better technology for and cost of this gamma radiation. Lyophilization is again very important. Again it can be combined with cryopreservation, and it can be used for again emergency purposes, tectonic purposes, and lamellar corneal surgery. So to summarize, primary objective of a storage medium is to maintain corneal viability and integrity during intervening time of retrieval and transplantation, and with the discovery of newer intermediate and long-term storage media, utilization of corneal tissue has increased without compromising quality. In COVID era, it has given insight to the basically long-term storage media. So there is a lot interest towards the long-term storage media also.
Dr. Vandana.
Thank you very much for patient hearing.
Thank you, Dr. Amit. May I now request Dr. Vandana Parasar to give her talk on specular microscopy interpretation. In the meantime, may I request Ashish to throw some light on preservation of corneal donor tissue.
Good morning all. Thank you for giving me this opportunity.
It's okay, thank you.
Specular microscopy, it is a non-invasive diagnostic tool which is used to evaluate and corneal endothelial cell morphology and document it photographically. These are various types of specular microscope. It has a lot of clinical application in endotheliopathies, but most commonly you have to remember it becomes a must indication when one eye patient is presenting with pseudophakic bullous keratopathy and other eye you are going to plan for surgery. So David Morris is a name to remember, as most of the modern days clinical specular microscope are based on the principle given by this man. The principle of specular microscopy is specular light reflex, that is mirror-like reflection from the aqueous humor and endothelium interface because of the difference between the refractive index of two media. This reflected light is captured and the endothelial image is formed. This is a normal endothelial cell mosaic of hexagonal cells. So you require a good quality of image to visualize your endothelial cells. When your cell boundaries are not visible, go for a manual method of analysis. This is a report printout of any specular microscope. It may differ from companies to companies but consist of basically same parts. First part will tell you about the patient detail with age of the patient. Second part is telling about the qualitative analysis, giving you the photographic and trace image of your endothelial cells. Third part is telling you whether the central part or paracentral part of the cornea is captured. Fourth is your numerical data, giving you indices for your quantitative analysis. Then fifth is your histograms, apex histogram, which tells about the pleomorphism. It is a graphical representation of number of apex of each cells. Then second histogram is area histogram, which is telling about the polymegathism. This is graphical representation of area of each cell. There are various analysis technique. Mostly we do frame method. In this we prefer variable frame method as it removes the border cell error of fixed frame method. Before going into interpretation, we should be well versed with two terms. One is polymegathism and another one is pleomorphism. Polymegathism is poly plus mega, that is multiple mega size abnormal cells are present with your normal small cells. So this measures increased variation in individual cell area, which is depicted by increased in CV. And pleomorphism is pleo, that is more than expected normal morphology of cell, that is six-sided hexagonal cell. You will see round cell, you will see square cell, you will see increased variability in the cell shape. That is measured by reduction in hexagonality. That is, your hexagonality will be reduced in pleomorphism. So coming to quantitative analysis proper, firstly, N is not your cell density, but it is a number of cell analyzed in your scan. That is giving you accuracy of your scan, as your standard deviation stabilizes once you count more than 100 cells in your image analysis. These are your area parameters: minimum area of each cell, maximum area of each cell, and average area of each cell. Average area ranges from 150 to 350 micrometer square. Standard deviation is percentage deviation of cell area from mean cell area. Coefficient of variation is calculated by the given formula. It measures variation in cell size. Lower CV means more uniformity in the cell size. Normally it is less than 0.3. Polymegathism is present if it is more than 0.4. Coming to hexagonality, this is measuring number of cells having six-angle polygon shape, that is hexagon. Normally more than 60% of the cells are hexagon. Pleomorphism is present if the cells are less than 50% are hexagon. Cell density, it is number of endothelial cell present per micrometer square. It varies naturally with the age and the image capture. Any improper centration can capture your peripheral cornea and can give you false high reading. So normal endothelial cell density is 2500 to 3500 cell per micrometer square. So this here you can see the cell density decreases with aging and average cell area is increases with aging. CCT is of importance as specular microscopy is just giving you the morphology of the cells. CCT is only, that is central corneal thickness. It is an only indirect measure of endothelial function. If you notice corneal edema, you know that your endothelium is not functioning properly. So a healthy cornea biomarkers are low CV and high hexagonality. In this diagram, you can see if you will analyze different frame, your values will change. Your quantitative analysis changes. So qualitative analysis is also of equal importance. You look visually for cell borders, shape, size, any intercellular, intracellular bodies if present, any abnormal patterns if present. Most common pattern which we see is Gutte, which is dropout endothelial cell seen in Fuchs endothelial dystrophy. This has to be differentiated from pseudo-Gutte, which is a transient swelling of endothelial cells. Here you can see various grading of Gutte. Gutte, you see the cell dropout area surrounded by abnormal endothelial cells, and Descemet membrane above this is thickened. And below you have a specular microscope of unilateral uveitis presenting with pseudo-Gutte, having normal surrounding cell, and it resolves once the primary cause is treated. In Fuchs, you see Gutte and various grading of Gutte. In polymorphous endothelial dystrophy, you see vesicles, bands and placoid-like lesions surrounded by abnormal cells. Eye syndrome, you see reversal of dark light pattern, that is, inside of the cell body is dark and the cell border appears white. At eye bank, you do specular microscopy for grading of cornea, whether it is fit or unfit for transplantation, and to decide whether to take the cornea for penetrating or endothelial keratoplasty. So lastly, I would just conclude by saying that although specular microscopy is very much understated just for corneal disease diagnosis and follow-up, it has now become important for preventive aspect of corneal diseases. And we should respect our endothelium. Patient आता है बोलता है vision के लिए lens लग गया. As ophthalmologist, we know lens लग गया is not enough. Thank you so much.
Thank you, Dr. Vandana. May I now request Dr. Ankita Singh to present on ocular trauma unpacked, different eyes, different stories. Ajit has sacrificed his talk.
Good afternoon, everyone. Today we are going to see few case series of ocular trauma, different eyes of different stories. Consent were taken from all the patient. Ocular trauma is an important cause of visual impairment and leading to preventable monoocular blindness. 1.6 million people are blind from eye injuries, 2.3 million are bilateral and 19 million are unilateral. In India, over 500 lakh people suffer from blindness, and every year blind population increases by 38 lakhs. So this is the first case where 18-year-old male patient came with alleged history of RTA 1 week back. He complained of diminution of vision of both eye, and there was history of nasal bleed, unconsciousness since 10 minutes, for 10 minutes, no history of vomiting. On systemic examination, there was fracture of mandible, left arm, right foot. Systemic examination were within normal limit. Now coming to ocular examination, multiple, as we see in this picture, there were multiple abrasions all over the face, and sutures were present in left eyebrows, below the eyebrow. Visual acuity was PLPR in right eye and finger counting half meter in left eye. So on right eye examination, there was lid edema, periorbital edema, subconjunctival hemorrhage, and full thickness corneal tear from 5 to 12 o'clock, along with the scleral tear. And on left eye examination, there was a limbal to limbal tear from 2 to 10 o'clock. On ultrasound, both eye was normal, CT orbit was normal, and right eye surgery was done, corneoscleral tear repair with iris abscission, but on day 1, the scleral melting was noted, and scleral melting went on increasing, so the patient went under TPK. So this was the history of the patient, that right eye after repair went under TPK. The left eye went under corneal tear repair. This is the post-operative pics. The case 2 is 58-year-old male patient came with chief complaint of diminution of vision, pain, redness, watering since 1 day. There was alleged history of assault, history of PK in right eye 8 years back twice, and history of evisceration left eye 9 years back. So basically the patient was non-eyed now. So this is the pre-op picture of right eye, where there is a dislocated corneal graft from 12 to 6 o'clock with anterior chamber hyphema. On ultrasound, the right eye showed vitreous hemorrhage, and the patient underwent corneal tear repair under LA under stream guarded visual prognosis. And this is a post-operative picture. Case 3 is a 45-year-old female came with chief complaint of diminution of vision of right eye since 1 week, and she had alleged history of trauma with banging the door. On ocular examination, right eye was hand movement PLPR and left eye 660 with no improvement. Right eye showed corneal edema with cruciate-shaped lamellar tear with central tissue defect. Patient went under glue BCL, the glue was displaced, and then the patient was again planned for glue BCL, and this is some surgery. See, as you can see, the glue BCL was tried, and I was trying to form the AC, but the AC was collapsing. So ultimately, the Tenon's patch graft to give the strength to the cornea was done with interrupted and infinity sutures. And the patient had similar presentation in the left eye also. These are the some few pictures of pre and post operative corneal tear repair. Thank you.
Thank you, Dr. Ankita. We have our guest of honor in the hall, so we'll be breaking for the inauguration ceremony, and then we'll be continuing with the rest 2 talks of this session after the inauguration. May I request Dr. Satyajit to take over the podium for inauguration.